Good afternoon and a warm welcome to all of you to the Lung Health and Oncology National Conference 2024, brought to you by IHW Council. I'm your host, Anisha Nair Thavan. Approximately 1 in 9 people in India are expected to face a cancer diagnosis sometime in their lifetime. Lung cancer is the most common cancer among men in India and is amongst the top 5 cancers affecting women in our country. Lung cancer varies between Caucasians and Asians. There have been differences recorded requires an in-depth understanding of the similarities, differences, and unique features of the kinds of lung cancer being seen in India. In most countries in South Asia, various issues add to the complexities in the management, including lack of access to testing and new molecular targeted therapies, financial difficulties, and the prevalence of infectious diseases like tuberculosis. This is why today's conference is very significant. This distinguished national gathering brings together influential stakeholders from government agencies, the healthcare sector, the allied organizations, all devoted to advancing lung cancer management and personalized healthcare in India. An impactful forum fostering knowledge exchange and collaboration to advance precision healthcare and elevate standards in lung cancer treatment. IHW Council has been at the forefront of advocacy for cancer awareness, as knowledge and early detection is the best defense against this disease, whose burden in India is projected to grow to 1.57 million by 2025. IHW Council has been regularly hosting online information sharing webinars with leading doctors and healthcare practitioners so that people become aware of the risk and symptoms of cancer and they can freely talk about it without any taboo. We will keep talking about cancer prevention and create more opportunities to build global awareness and ultimately more impact. We would like to thank AstraZeneca, Qure.ai, and MedGenome, our event partners, for their support. Sudpatam Super Specialty Hospital is our associate partner, and we are supported by Lung Connect and Lung Care Foundation. Here is the video about the undying efforts of IHW Council across different health campaigns it has pioneered.
In a world where health defines potential, diseases become barriers to growth. Weaving dreams of a world without sickness and full of well-being, the Integrated Health and Well-being Council was born. At its core, the Council stands for the high five of health. Good air, good food, good water, good living, and good health care for everyone. Aligned with the United Nations Sustainable Development Goals, the Council firmly works towards making sure health reaches every corner of the world. IHW Council has built prestigious forums for holistic health discourse, like India Health and Wellness Summit and Awards, CSR Health Impact Awards, CME Excellence Movement, Ayushman Bharat Conclave, Jal Shakti Conclave, Digital Health Summit, Patient First Summit, the Good Air Movement and Summit, Rapid Global Cancer Alliance, and the She Alliance for Spirituality in Health and the Environment. These initiatives have received wholehearted support from policymakers, industry captains, community leaders, health experts, celebrities, and influencers. Respected brands and advocates have also joined the Council, becoming allies in the mission for a healthier world.
I think this wellness is an important initiative. I will definitely be interested to know the conclusions of your deliberations, and I'll definitely take these issues and your suggestions forward to the logical conclusion.
हेल्थ सर्विसेज कैसी होनी चाहिए, ये तो महत्वपूर्ण विषय है ही, पर उसके पहले हमको हॉस्पिटल या डॉक्टर के पास जाने की जरूरत न पड़े, इसके लिए हमारे एयर पोल्यूशन और वाटर पोल्यूशन को हम कैसे सुधारें, इस बात पर जोर देने की आवश्यकता है।
कहते हैं क्षिति जल पावक गगन समीरा, पंच तत्व निर्मित यह अदम शरीरा। ये पंच तत्वों से निर्मित यह शरीर पुनः पंच तत्व में ही मिल जाता है। तो हमें उन पंच तत्व का, जिससे इस शरीर की रचना हुई है, आकाश, पृथ्वी, अग्नि, वायु, जल, इन सबका ख्याल ही नहीं रखना, बल्कि इन पंच तत्वों का रक्षा करना हमारा पहला कर्तव्य हो जाता है।
In the digital world, the Council reaches millions with credible source of knowledge empowering them to protect their health and prevent diseases. Through its various initiatives harnessing the power of social media, the Council impacts over 100 million lives annually. Join IHW Council in creating a world where limitless potential knows no bounds. Together, we can achieve a happier, healthier world for all.
I would now like to invite on stage Mr. Kamal Narayan, CEO IHW Council, to talk to us about what's coming up in the day today. Please put your hands together for Mr. Kamal Narayan.
Thank you, Anisa. Good afternoon, everyone. On behalf of IHW Council, I welcome all of you to this Lung Health and Oncology National Conference here at Ambedkar International Center. The significance of today's event and also the location and the city where it is being taken is important, because when it comes to lung cancers and lung health, one of the major component or the major cause which we have seen, which leads to this problem, has been identified as air pollution as well. And the city of Delhi, we have all seen, and many of you, though many of our guests have come from other cities from across the country, but many of our guests and participants today are from Delhi, and we have seen the last 1 month and so having one of the worst AQI. We are some of the emergency measures put by the government to reduce or to control the pollution and improvise the air quality, just got lifted a day back only. So what we expect that through this conference, we will be able to understand the etiology between the air pollution or the many other causes, the industrial pollution, the lifestyle issues, increasing use of tobacco, smoking, many other regions which lead to lung cancer or the compromising the lung health of the people. As part of IHW Council's advocacy work, we strongly and consistently been working on the area of cancer awareness, prevention and control, which is also our commitment under the SDG goal, which denotes to or connect to well-being for all. And the goal number 3.4 specifically highlights about, is preventing the deaths and mortality and morbidity being caused by the non-communicable diseases. And when it comes to cancer, this is one of the most critical and most important public health problem which we are seeing. I always feel, and also I feel pained many times, that why we have not been able to put that kind of attention and focus or the policy priority in controlling cancer or creating a health system which can combat this problem effectively. We all saw one of the major health crises in the form of COVID-19. And though many times people feel that this parallel may not be correct, but I do see an important significance in the parallel which I am trying to draw in front of all of you. In the COVID-19 pandemic, when we saw the whole world putting its, the most stringent measures, actions, and also, stopping almost every activity around us, which actually defines the today's growth, we saw a kind of death burden which was far lesser than what cancer is causing. For that matter, in India, almost 14 lakh cancer cases are identified or diagnosed every year, out of which almost 8 to 9 lakh deaths are recorded. If we compare it with the COVID-19, in the entire duration of the COVID-19 in India, the official death figure hovers around 5 lakh. While we are losing almost 8 to 9 lakh people every year due to cancer and different type of cancers. Lung cancer is also being in one important contributor to that. Almost 77,000 cases being diagnosed, out of which maybe 60,000 people die of this. So I believe that this conference, the esteemed experts, the medical speakers who come with with lot of knowledge and experience and their practices in ensuring that the best of the cancer care is provided to the people, will be able to identify various emerging protocols, therapies, also the role of technologies, which is improvising, which is important to ensure the access of cancer care for the people who need it, and to make it more accessible and affordable, and also more effective. And also at the same time, we will be able to take the awareness about lung cancer and the various other factors which are impacting the lung health of the people to far and wide through our also with our friends from media who have joined today in this conference. And with this, I kind of a wish that today's summit and the conference is going to yield that kind of outcome which will help addressing the emerging cancer problem in our country in a much better way. And with that, thank you so much for participating in this and for your time. And we are looking forward to a very productive day ahead. Thank you.
Smoking, growing air pollution, and industrial exposure in urban areas are the key risk factors for rising incidence of lung cancer in our country. Lung cancer has one of the lowest 5-year survival rates because the cases are often diagnosed in later stages where the disease is less likely to be curable. We will start our conference with a plenary talk. So please put your hands together and welcome on stage Dr. Saroj Das Majumdar, Professor and Head of Department, Radiation Oncology Department, AIIMS, Bhubaneswar. We look forward to some strategies for early detection, raising public awareness and improving healthcare infrastructure for the management of lung culture. Over to Dr. Majumdar.
Namaskar. Good afternoon, everybody. It's a privilege to be here. I thank the organizer. I see the distinguished guests from different specialty, so it is unique for me. Like 2024, but lung cancer 200 years before, we know a scientist called Linnek. René Linnek invented stethoscope. And he also first told there is a malignancy in the lung. The concept of lung cancer came that time. This René, he died of tuberculosis actually. So this is what Adler in 1912, he actually published the first literature in lung cancer, Adler. It was published in Green Journal that time, and he told that this lung cancer is always underreported. This was his concept which came 200 years before actually. The Dr. Davis in 1912, again, he first invented a procedure called lobectomy. Part of lungs was removed, but that first patient did not survive because the anesthesia, other support system was not there. The first successful pneumonectomy, whole of the lung was removed by Dr. Graham in 1933. Why I am telling this? After 200 years also we are not successful in dealing this lung cancer. Radiation, if you know, I am from radiation specialty. In 100 years before, X-ray came, 1895. Just after 2 months, it was employed to treat cancer patient. First patient was breast cancer patient. And immediately lung cancer also, they tried to treat that. Some patients, they improved, some they did not. In 1950s, the linear accelerator came. Actually technology is coming. Why they started with stethoscope, lung cancer we came to know. Then X-ray came, we came to know disease from within. Then the treatment also started immediately. Just after discovery of X-ray, 2 months after that, treatment was started with radiation. Radiation is just X-ray. X-ray, gamma rays, radium, uranium, all discovery started. At the same time, they were employed for the treatment. 1950s, the advanced linear accelerator came. And this machine was used for successful treatment of lung cancer. So the Department of Radiation Oncology came in 1950s. When Second World War was there, nitrosamine gas was used in the gas chamber. Accidentally, we came to know that this is also working to kill cancer. So chemotherapy came in picture to treat cancer like leukemias and also including lung cancer. Subsequently, it's not a single entity. Subsequently, we have pulmonary medicine, pathologist, radiologist, nuclear medicine, palliative care, all this multiple specialty came. So it is not a single disease. So lung cancer means I am happy to see many people from different background. Some are from IITs, from technologies, some are from investigator for research corner. So it is very much required. We are in the clinic, but end of the day we need everybody to fight this deadly disease. This is just to tell you, just set the tempo of this symposium today. You see lung cancer in male cases. In male, it is second, incidence is second, lung cancer. But in female in India, it is not beyond fourth. But if you combine both sexes, it is in fourth position. Roughly 80,000 new cases are coming every day, lung cancer. Why? These are the problems with us. The more we are going towards development, we are exposed to the risk of developing cancer. As we know, radiation from like investigational radiation exposure, once we take a chest X-ray also we get radiation, CT scan we get radiation, background radiation, we fly also radiation. So it is beyond doubt that radiation was the cure, it was used for the cure, and also if it is not used judiciously, it can cause cancer also. Aging population is coming up. The more and more infectious diseases are controlled, we are now getting the exposure for these malignancies. So the aging, then the pollution, as my previous speaker told, pollution, it's like Delhi in particular, so it is causing injury to the lungs. It's very pathologically, two lungs are compared. The one without smoking, another one is with smoking. You will see how big difference is there. So lung is exposed to pollution with 10-15 years incubation time, the cancer incidence will rise. Similarly, environment, other diseases like COPD, genetics will cause nearly 20% of cases. 30% you will see without any risk factor because of their genetic problem. So that we cannot help. But other things, lifestyle diseases, we can definitely control. So I think, yeah. One problem in India is that India as a country, you will see so many heterogeneity. If you go to a rural area, maybe 30 out of 1 lakh population will have cancer. You go to any cities, or mostly in the Mizoram, Northeast, the incidence is highest, 170 in 1 lakh population. So these differences are there. It is another challenge for us to tackle this. So we don't have any indigenous policy or which state or which region is having what type of disease more. Like I come from Odisha, we see mostly stomach cancer. Stomach cancer because they take lots of betel, they chew betel nuts. So stomach cancer is very common. Head and neck cancer, oral cavity cancer is common. In Mizoram, smoking is very common habit. That is why lung cancer is very high. Again, the cancer is not a single entity. One cancer cell is multiplying in 8 days time, another one in 30 days time, another one in 80 days time. So they are also different. So one more thing, underreporting of lung cancer is that tuberculosis is very prevalent in India. The symptoms of TB and symptoms of cancer is similar. That is why it is underreported. I was just checking both sides, symptoms are almost similar. So that is why diagnosis is also difficult. Just to highlight that we are in difficult situation, more challenges because of public awareness is less, late presentation. As we know, early stage cure rate, again, stage 1 breast cancer cure rate is 90%. Stage 1 colon cancer 90%. But stage 1 lung cancer cure rate is 70%. Why that difference? So it is totally different disease. Killing is high. Again, patient is presenting not in stage 1. They come in stage 4, stage 3. Then cure rate 5 years. Cure rate is just 5%. At the end of 5 years, you will see only 5 are living. So abysmal outcome. Again, unequal access to the treatment or the health care facilities. In this country, you go to a place like in Delhi, everything is available. You go to another place, maybe radiation machine is not available, maybe oncologists are not there. So this heterogeneity is there. Unequal access and limited diagnostic facilities. Now we are in teaching institute, so our diagnosis system is well developed. Like a small biopsy also, liquid biopsy, we can know about the disease, genetic profile, gene sequencing, everything is there. You go to another district level hospital, it is not available. So heterogeneity is there. We don't have any guideline for our patient. What we do, we take the information from Western country, then we try to treat with that. But we are genetically different. Our problem is different. So this forum maybe will help us to create indigenous formula, indigenous guideline for our patient. And always there should be a multidisciplinary approach to this deadly disease. It's not a single person's job, starting from diagnostic to surgeons, medical oncologists, radiation oncologists, palliative care, all have to be together. So today we are going to also discuss about this multimodal treatment or tumor board sort of thing. We'll discuss about this. So I hope it's just why I'm telling that still we are hopeful. Better days are coming. Just a real picture of my patient, a stage 4 lung cancer patient. You can see this side PET CT scan showing liver, lungs, bone, everywhere studded with cancer. But after 4 months therapy of immunotherapy, this patient, a 72 years old gentleman, got cured of diseases. So this is also possible, like miracle in the medicine also. It is all because of science, technology, and support from all corners. So thank you very much. Hope today's discussion will be very helpful to all of us. Thank you.
Now that we know that late diagnosis is the reason for the high mortality in lung cancer, we have to come up with good screening techniques to catch the disease early. Low-dose computed tomography, LDCT scan, can detect potential cancerous growth before the symptoms appear. But this is considered the best option for high-risk individuals, mainly those who are heavy smokers. What about those non-smokers presenting in late stage 4 cancer? We now have presentations on the latest cutting-edge technologies that may have an answer to this question. So we are going to start with presentations. Our first presentation is on Qure.ai, where AI technology is transforming lung cancer screening by improving accuracy in radiology image analysis, enabling faster and more precise lung cancer identification. This session will explore real-world application of these AI-driven solutions and their impact on clinical workforce, particularly in resource-limited settings. So please welcome our speaker who's going to be talking about Qure.ai. Please welcome on stage Mohammed Yahya, Director, CEO's Office at Qure.ai. Please give a round of applause and welcome Mohammed on the stage.
Yeah, good afternoon, everyone. I think the speakers before me clearly established, the burden of lung cancer, right? I will talk more about how technology is actually creating disruptions in lung cancer diagnosis, particularly AI. How can it help with early stage diagnosis of lung cancer? So before I introduce Qure, I just wanted to give a small example about how pathology as a field got disrupted in the 1980s, right? So till the 80s, pathologists spent a lot of time under the microscope, doing a lot of manual calculations, even for the simplest of tests like blood cell counts. Now that is not the case anymore because you have these automatic analyzers which can quickly estimate blood cell counts, and pathologists have obviously moved on to more complex tasks. We think radiology is also, or imaging diagnostics is also at this particular juncture where AI can potentially aid in the reporting of every modality, starting from X-rays to CTs to MRIs. And this is particularly important because radiology, again, as a profession, is not developed in many countries, right? There's a severe radiologist shortage in many countries, including that of India. So AI, if deployed at scale, if deployed correctly, it can potentially solve some of these problems. So Qure, we are a health tech AI company, particularly working in the field of medical imaging AI. In short, what we do is our AI tools automate the interpretation of medical images, right? And we currently have capabilities for X-rays and CTs, and we focus on multiple disease areas. We started with tuberculosis, now we focus on lung cancer, and also for stroke. So we started operations in 2016. Currently, we are deployed in over 90 countries. We roughly work with over 3,000 hospitals, medical centers, screening camps all over the globe, right? You can see the dots on the map here. We have in fact been very successful in deploying AI in across the entire spectrum of healthcare delivery, right? Like right from low resource healthcare settings where you have scarcity of doctors, where even internet is a big problem in countries like Africa, all the way up to tertiary healthcare settings in the US, UK, and India. On an annual basis, we roughly touch about 10 million lives across all of our imaging modalities, right? So as for any AI first company, data is like, the fuel, right? In fact, we put a lot of emphasis on the data that are used for training our AI models. And we, in fact, hold a very large data library of over 1 billion images, which covers all the modalities across X-rays, even ultrasound and MRIs. And we are very well poised to develop foundational models in radiology. So just to talk a little bit more about the burden of lung cancer in India, I think the speaker before me, Dr. Majumdar, he mentioned that early stage diagnosis is a big challenge, right? And in India, it's still worse. Globally, I think the average is somewhere around 60 to 70% of the cases are being diagnosed in stage 3 and stage 4. But in India, the problem is even worse. More than 90% of the cases are being diagnosed in late stage. So the treatment outcomes are bad, the survival rates are bad. So the key over here is to actually detect or catch more lung cancer patients in stage 1 and 2. And it is a challenge because most of these patients are asymptomatic. So how do we go about doing it, right? So again, this is a problem in India because a lot of times, lung cancer also gets reported as TB. There is no proper data collection mechanisms which are there. And we do not have proper guidelines or protocols in place in case nodules are found on, X-rays, right? So what could be an answer over here is screening. It gives a part answer, but we need to take a very radical or different approach towards screening. So how do we go about doing it, right? So in some of the developed countries, they have tried doing targeted lung cancer screening programs. So imagine this red box is the entire population, and you have the at-risk population, which is a subset of this. The at-risk population would be the people who are at high risk for lung cancer based on the smoking history, based on the age, and once they are identified, then the country takes measures to reach them and put them under screening through low-dose CT-based screening programs. But then even the LDCT programs won't be able to capture the entire bucket, right? They'll only be able to capture a portion of the at-risk population. And then once screening is done, there would obviously be follow-ups in the screening funnel. And there would be dropouts or there could be loss during the follow-ups. So the percentage of patients or the portion of the patients that would be getting diagnosed with lung cancer would only be this particular portion, right? So how can we do this differently? That's what we are doing in partnership with AstraZeneca. So what we call this the incidental screening approach. So now imagine the same scenario. We have the entire population. So X-ray, chest X-rays especially, it's a very, very common type of imaging. A lot of people, at least all of us at some point in our lives, we would have undergone a chest X-ray, right? So we again have the same at-risk population, but the patients with X-rays will be a lot more. So why not put AI as a surveillance tool which works at the back end and sort of analyzes all of the chest X-rays and only flags those X-rays which could have potential high-risk nodules. So if we do that, we'll be able to catch we'll be able to broaden the funnel for screening, and we'll be able to catch more lung cancer cases early on. This is what we've been doing in partnership with AstraZeneca since the last 4 years. So how do we go about doing it? So we have an extensive product portfolio, extensive set of AI tools, and also patient workflow applications, which help in ensuring that there are minimal losses to follow up during the lung cancer pathway, right? So the first application that we have is Qure.ai, which is a chest X-ray AI. It is highly accurate in detecting lung nodules on chest X-rays and also characterizing them as high risk for malignancy or low risk. And then we have the QCT product, which is AI for chest CTs, which can do an even more detailed characterization of lung nodules. It can automatically measure the size of lung nodules, the volumetry, the border characteristics, whether it is speculated or not, whether it is calcified or not, all of that. And Qure.ai is our patient workflow application, which is a care coordination platform which tracks all of the patients in the lung cancer diagnosis pathway. So talking a little bit about the uniqueness of the chest X-ray AI that we have. In fact, this is the first AI tool on chest X-rays which has a patented feature which is the lung nodule malignancy feature, right? So basically, our AI is trained on X-rays of confirmed lung cancer patients, so it can accurately identify those nodules which are high risk, and then these patients can be put on the screening pathway. So we've been doing this in partnership with AstraZeneca for the last 4 years. In 2021, we undertook a commitment to screen 5 million patients by 2025. And we've been running this program across several countries, about 28 countries, across different regions in Asia, LATAM, Middle East, across Southeast Asia. And we are on track to reach 5 million screenings by early 2025, right? Specifically talking about India, in partnership with AstraZeneca, we have screened close to a million patients, and our AI has flagged about more than 1 lakh nodules, out of which about 5,000 lung nodules are found to be at high risk. And we are putting in place measures to follow up all of these high-risk lung nodule cases and put them on CT-based screening and, if required, biopsy to confirm presence of cancer or not. Now, let's actually look at some real-world, examples of how our AI was very instrumental in catching lung cancer patients early on, right? So this is the X-ray of an actual patient in Hyderabad at a hospital where our AI was doing the surveillance for lung nodules. The patient walked in for a general checkup, and an X-ray was taken. The QXR AI flagged a nodule, as you can see on the left lobe. And then it was found to be, the AI flagged it to be a suspicious nodule, and then the patient was asked to undergo a CT-based examination. And based on the CT test, it was found to be a high-risk case, and biopsy confirmed presence of, lung cancer. And it was a stage 1 case. And if you catch a lung cancer case in stage 1 or stage 2, it is very much possible to treat it, and the 5-year survival rates are much higher, right? So there are more such stories. All of these are, examples of our AI being helpful in catching cases in stage 1 and stage 2. The first one is of a patient who walked in for an anti-TNF treatment, an X-ray was taken, and then another patient who came for a general checkup, and then X-ray of a patient was taken for a pre-operative case, and we were able to catch all of these cases in an incidental manner, right? So how does the future look like when it comes to lung cancer screening, especially in a country like India, right? So we are taking a lot of measures. We are doing a lot of projects in close collaboration with both the public and the private sector to ensure that this incidental screening approach is deployed in as many areas as possible, right? So particularly in India, we have made deep integrations with the public health system in Goa and in Karnataka. In Goa, we are practically deployed in all the district hospitals over there. In Karnataka, we are deployed in over 19 district hospitals where our AI is working as a surveillance tool. So the goal over here is to, raise awareness to the problem, right? Like, one is around the incidence of lung cancer. 2 is that most of these lung cancer cases are getting diagnosed in late stages. And ultimately, we want, to create a call to action from both the public and private sector towards the need to solve this problem. So how are we going to do it? So just to explain the workflow, a patient walks into a clinic, he's taking routine chest X-rays, and then these chest X-rays are, analyzed by our AI for presence of nodules or not. And if the AI is going to flag it as a high-risk nodule, then it would flag it to the radiologist or to the pulmonology or to the appropriate, referring physician. Based on his recommendation, the patient can undergo a CT-based examination, followed by a biopsy confirmation. And this entire workflow can be managed using our care coordination application, which is the Qure.ai. And we should have roles like nurse navigators who can ensure that there are minimal loss to follow-ups in this entire funnel. And then obviously the pulmonologists are also in the fray to ensure that the patient is being managed properly. If you look at the areas which are marked with Q, these are the intervention areas for AI. Yeah, so this is how we think AI can be deployed at scale and how it can help in early stage diagnosis for lung cancer. Thank you.
This tool does seem to be very promising, and I would like to invite on stage Colonel Rajiv Manali, CEO, Sud Patom Super Specialty Hospital, to speak with Mohammed about how this can be applied in everyday hospital settings and what is the recourse available to patients. Will this only be during unsuspected walk-ins, or can we actually schedule screenings of CTs? So please put your hands together and welcome on stage Colonel Rajiv Manali and Mohammed Yaha Pak on stage. I request hand mics be given to our speakers so that we can all hear them.
Good afternoon, ladies and gentlemen. It's a pleasure being here on a Saturday afternoon, getting to know more about the screening, detection, and other facilities and looking after the lung health on the whole. And I must make it a point to compliment IHW Council for organizing such a very, very deliberate, thought-provoking awareness session on lung health and lung cancer. I must also compliment here, we have listened to some of the speakers already. We have also listened to Mr. Mohammed Yaha. The pioneering work being done by Qure.ai in putting this application of AI into screening and detection, I think it's fantastic. We've been hearing about the potential of AI into healthcare, helping healthcare workers and healthcare providers in detecting, screening, etc. The potential is huge. We have still not tapped the tip of the iceberg. Here's a company, and that too an Indian company, which has pioneered it into this pretty early, 2016, so they were the early birds, I would say, and having done such phenomenal work already into this aspect. As you would know, lung cancer is a pretty serious affair. The contributory factors, we all know. We know the magnitude of the problem. India, with its huge population, screening and early detection is actually a nightmare. Now, this is where the applications of AI come in. And this is what we must now start propagating and making use of. I will just take you back to Kerala, where I belong. I am from SUT Hospital. It is not SUT Hospital, as someone mentioned here. I would pronounce it correctly. It is Sri Uttradam Tirunal Hospital, and SUT is an abbreviation for that. And since I am on the topic of SUT Hospital, I would like to mention here, this is a hospital. It's a corporate hospital, of course, but this hospital is a brainchild of one of the former Maharajas of the princely state of Travancore. He actually donated his palace for starting this hospital. So I think I belong to this hospital, and I'm the CEO of the hospital, which is possibly the only hospital in the world which is operating out of a palace. Now, this we in Kerala, we've recently, in the month of National Cancer Day, we launched a public-private partnership termed as Cancer Safe Kerala. Now, it's a the organization which started this program is known as Swasti Foundation. Swasti Foundation has been able to bring in the government as also the private players together to ensure that this total awareness created on cancer and screening and detection is carried out with a view to eliminate cancer in a foreseeable future. Once again, it's a huge task. But Swasti Foundation is so passionate about it, I am sure they will be able to do something in the foreseeable future. Now, I see the potential with initiative being taken by IHW Council and agencies like this into spreading this across the country, because ours is a huge country. There are inequalities all over, rural-urban divide between the states, north, south, east, west, etc. They're all there. Huge population, limited resources. But then, how do we overcome this? We now need to talk more about our capabilities to overcome the challenges than talk about the challenges. Challenges are there, we all know about it. But how do we overcome it? Let that be the area where we focus on. And seminars like this and also webinars, etc., on this topic, I think will go a long way in ensuring that there's an awareness across the country, and the governmental agencies are energized and they bring into play other private players and also people who are NGOs and others who are passionate about this, and create a public platform where we can do and we can walk the talk. With this much as an introduction, we have all seen the presentation made by Mr. Mohammad Yaha. I would like to know, on your behalf, it's a profit-making concern, Qure.ai, no gainsaying the fact. But how can this be put into the public domain using the governmental agencies for this purpose, and ensuring that there's a commonality of purpose, commonality of approach, and cover the entire country in such a way that firstly awareness, and along with awareness, screening facilities are taken to wherever the people reside, irrespective of the fact that they have the resources or no. How can we make this happen? I'm sure it's a brain's trust. We are all part of it. Answers can come from anywhere. I am posing the question to Mr. Yaha so that the question is thrown open to all of you, and we could collectively think about or think out some ways and means to do it, and put it, I'm sure IHW Council will put it across to the governmental agencies so that there is an acceptance and action can follow. Over to Mr. Yaha.
First of all, Colonel, thanks a lot. I think it's a pleasure to be sharing the dais with you here. As you rightly said, there is, the lung cancer burden is established. How do we go about scaling this at a large scale within the public health systems? So I think we need to take, one step at a time, small steps at a time. So in a country like India, the sensitization towards AI is is not that high compared to the Western world, right? So what is more critical for the public sector also to participate is to build evidence around the efficacy of AI, which is precisely what we are also doing. So we are building a lot of, we are showing evidence around how AI is accurate in picking up these nodules. We are, publishing real-world evidences around it. We are working very closely with clinicians and doing research work around, the accuracy of AI. We do both retrospective and prospective pilots, and then we publish this in peer-reviewed journals. So that is, one of the steps just to gain acceptance. Two is you start, in one portion of the public health system, you do it, and then you show what kind of benefits that the public health system can attain, right? So, like I said, if a country like India were to institute a targeted lung cancer screening program based on LDCT, it's going to be very, very expensive. We already have a lot of X-rays lying around in public health systems. So why not, use that corpus of, or that archive of X-rays and, just go back into the past for about 6 months or 1 year, and then look at cases that could be followed up. And then we institute a program for follow-ups. We appoint nurse navigators so that these patients come back for follow-up diagnostic procedures. So that could be one way of doing it, right? So, yeah.
Thank you. I think that's a very practical solution of digging into the archives where every hospital, even the governmental hospitals, primary health centers, they all have X-rays and facilities to carry out X-rays. Maybe can dig into the archives also and do it even prospectively and use the AI to screen these X-rays which are available and come out with, detection to the extent possible. Lot more needs to be done, but then somewhere a beginning can be made. I would also like to throw this question open to the audience here. If you have any ideas, I think it may be welcome so that ultimately we can put this together and make out some sort of a recommendation to the government too at the end of the day. Mr. Kamal Narayan, would you like to say something on this?
Just ask one thing. As you mentioned that we can go to the archive and at least for one last year of X-rays which has taken place.
Could be, used as a repository for AI to, run through, and then you may, discover certain cases which can be followed up.
Yeah.
So, apart from the government sector or the public hospitals, how much this has percolated in the corporate hospitals? Because they do have an incentive also if they are able to discover or diagnose cancer patients. They the patient can become a further source of revenue for them as well.
Correct.
So is it like they are open for that? I'm talking about all the large chain.
Yeah.
You talked about certain hospitals where you have deployed it, but how is the?
No, I think you're right on point, right? So in India alone, if we just talk about the screenings that we have done, I think the public-private participation has roughly been 50-50. So the private sector is also very keen. In fact, they are always the early adopters of technology because you have to go through less or lower levels of bureaucracy to get a new technology adapted by them. See, the challenge, so they have, the answer to your question is yes, they have done it. They're also very keen on using AI for, detecting early stage cases. The challenge has always been in the follow-ups, right? There will be a lot of loss in the patient funnel while doing these follow-ups. Like the moment you tell a patient that, you should come back for further screening, they usually get scared. And oncology patients are usually called as travelers because they don't, stick to one particular provider as well. They always like to seek opinions from, different hospitals as well. So the challenges are there. So that's why we are also trying to work on the follow-up part. So where we have developed these applications to ensure that these patients are tracked in a single platform and these patients are called back for screening. Obviously, we are also encountering some loss in the follow-ups, but it has been minimized from what it was earlier.
So I just wanted to check from a very layman's perspective and let's say personal account. For example, I went for a preventive health checkup, which is, everyone should go for that. In last couple of months to one of the biggest corporate hospital in Delhi, which also included a chest x-ray.
Correct.
Now, let's say, because I live in Delhi and I am exposed to one of the major high risk of lung health issues, including lung cancer. So, does that hospital has this AI as a surveillance tool? And if it has, because if they have, then there is a possibility for me to, if I somehow or by any chance, if I have developed some malignancy, I can get that early, diagnosis.
Correct.
So that's the reason I'm asking this.
So see, a lot of hospitals, at least the partner hospitals that we have, right? So see, let's try and understand the approach over here. So why we are calling it incidental? Because when you go for your X-rays, normally the referring physician is trying to look for some kind of abnormality based on the complaint that you have gone for. If it is a general health checkup, they'll just look at the overall overall X-ray and see if there are any abnormalities or not. But the AI is going to actually screen for a bunch of abnormalities, because we have trained our model on about the latest version of the chest X-ray model that we have is trained on about 9 million X-rays. And particularly nodules, it has been trained on several hundreds of thousands of confirmed nodule cases as well. Yes, you can. So once the AI flags it as a suspicious nodule, we only refer it to the physician, and it's entirely upon the physician's discretion whether to call back that patient or not. In high risk areas like Delhi, I think I'm not fully competent to say whether folks like us would be more susceptible or not. But yeah, it definitely increases the risk, and it also definitely increases the need for technologies like AI to be there as a surveillance tool at least, so that we catch it early.
I think from what we have just heard, I think it's very important to start at the governmental level, at the policy making level. The government could start at least with the high-risk areas, high-risk population, and high-risk categories such as smokers and industrial workers, miners, etc. Start there and identify those areas, and companies like Qure.ai could be brought in, along with other major healthcare players, private as well as public, and utilize the available resources to carry out screening at a very rudimentary level, then come down to detection. And it's also time to think about what after detection, how is the cure going to be also administered. So it is a huge task. It is not just the government alone can't do it, but the initiative as a policy has to come from the government. It has to be spread across the country over a period of time. And ultimately, I think if correctly handled, this has got tremendous potential to address the problems of detection of cancer, and especially lung cancer, in a big way in a country like India. Both the government, the non-governmental, as also the private players have to come together, put their hands and heads together, and walk the talk and make this happen. I think that probably is one of the purposes of this conference. And I think seeing you there, I know the time is up, and therefore let me wind up. Thank you for the very. Do we have time to take one question from the audience there?
Sir, still around. You can ask him offhand. We will continue the discussion of diagnostics of early screenings in our next presentation. So if you don't mind, just take it one-on-one with him. Please give a round of applause to Colonel Rajiv Manali and Mohammed Yahya. Let's hope Qure.ai is one technology which is available in government hospitals, in private hospitals, and helps in early screening. I would like to request Kamal Narayan to please come up on stage and present our speakers with mementos. We thank them for taking the time to come here and sharing the wealth of their knowledge with the audience. I'm sure we're all better informed on how AI can be a game changer when it comes to diagnosing lung cancer early. Thank you to both Colonel Rajiv Manali and Mohammed Yaya. We will continue with our discussion on screening and diagnostic tools. Early detection of lung cancer significantly improves survival rates, yet it remains one of the most challenging cancers to diagnose in the initial stages. To discuss how we can, pick up the disease in early stages, I'd like to call upon two speakers. So please put your hands together and welcome on stage Colonel Dr. Shafeen Babu, Associate Professor and Consultant Pulmonologist, Department of Pulmonary Critical Care and Sleep Medicine, Command Hospital, Eastern Command, Kolkata. Please put your hands together and welcome on stage Colonel Shafeen Babu. And joining him on stage is Dr. Anant Mohan, Professor and Head, Department of Pulmonary Critical Care and Sleep Medicine, AIIMS, New Delhi. Right. So please welcome Colonel Shafeen Babu.
Very good afternoon to all of you. And first of all, I would extend my thanks to the organizing committee to give me a chance to present the today's topic, screening in lung cancer. So without wasting time, I'll be moving to the topic, screening in lung cancer. So today's topic is screening in lung cancer. According to the Globacon 2020 data, out of 88,000 patients who are being diagnosed as a case of lung cancer, 80,000 people dies. So the mortality rate of lung cancer is very high, and it is one of the second commonest cause in males out of the all cancers. Coming to the clinical presentation, the patient may have dry cough, it may be persistent, sometimes blood in the sputum, hoarseness of voice, shortness of breath, then there can be fatigue, weight loss, loss of appetite, and some patient presents with chest pain. So the lung cancer is an important disease, and it has got maximum mortality out of the cancer diseases. So screening is very essential to diagnose this cancer at that early stage. Coming to the principles of screening, we can see it is an important health problem. Then the facilities for diagnosis and treatment should be available, and there should be a suitable test or examination, and that test should be acceptable to the population, and it should be cost effective. So this is the principle of screening. And coming to the diagnosis of cancer, the cancer stage 1 to 4 is there for lung cancer, and out of that, only 1.2% of the patients are diagnosed in the early stage. There comes the importance of screening at the early stage. If you see the stage 4, when the patient reaches to the stage 4, then only the diagnosis happens for more than 65% of the patients. The warning signals to go for a lung cancer screening are cough, blood in sputum, fatigue, and patients whose age is more than 50 years, and if there is a smoking history. Why is lung cancer diagnosed late? The answer is misdiagnosis as symptoms mimic other respiratory diseases, lack of screening in high-risk population, lack of awareness among the patients. So these are the reason why the lung cancer is diagnosed late. And patients with warning signs and symptoms of lung cancer were misdiagnosed as tuberculosis, as India is one of the most burdenable country for tuberculosis. And this is a study carried out by our esteemed chairperson, Dr. Anand Mohan sir. And other Indian studies also shows there is a misdiagnosis of lung cancer as tuberculosis. So the clinical and laboratory evaluations make up the first step to the diagnostic pathway of this lung cancer. For that, there should be a proper medical history taking. The doctor should take a proper medical history, then the physical examination and laboratory evaluation. Coming to the diagnosis of lung cancer, we can divide it into three. The first one is imaging techniques, then tissue sampling, then laboratory tests. Imaging, CT scan, PET scan, MRI, then bone scan, tissue sampling through a CT guided biopsy, bronchoscopic or endobronchial ultrasound guided. Then modalities of lung cancer screening. We can see the first one is simple method, that is a sputum cytology, then X-ray, low-dose CT scan. Then we can use PET scan, molecular biomarkers, autofluorescence bronchoscopy, electronic nose, genomic and proteomic analysis of bronchoscopic samples, then breath print analysis. Coming to the last session, they are still in developmental stage and theoretical. Even though somehow established their efficacy, but still they are in developmental stage and we have to do so many trials or studies. So the available approved screening tool is low-dose CT scan. The advantage is it's a low-dose CT scan. It doesn't have that conventional approximately 115 CT scan source. Then it produces satisfactory image quality. It reduces the CT dose index and reduces the radiation exposure. Then it is preferred for multiple scans as needed for high-risk patients, which we are coming to in the next slides. So this is the study of national lung screening trials. They showed there is reduced lung cancer mortality with low-dose CT screening. So when there is a low-dose CT screening, we can diagnose the patient early so that the treatment is started in the early stage and the mortality reduces. So this is another large trial, Nelson study, which was done in Netherlands, the Dutch study. They are also showing the evidence that the high-risk patient under screening at baseline, year 1, 2, 3, or approximately 5.5 years, versus no screening and follow-up 10 years, showed the reduced lung cancer mortality with volume CT scanning in the RCT. So this is one of the important studies which they have done and established that the screening of lung cancer is very essential. This is the Indian study by Dr. Bhavin Chankaria and Parag Sanghvi. Low-dose CT scan screening in smokers in India who are smoking 20 packages or more. The studies showed there is decrease in mortality. So coming to the benefits of low-dose CT scan screening, it decreases the lung cancer mortality as explained in the previous slides. Then it improves the quality of life once the diagnosis is there and the treatment starts. Then there is reduction in the disease and treatment morbidity, improvement in health and lifestyle, reduction in psychosocial burden. So once the patient has been diagnosed early, then he knows that there is a treatment and I'll be cured. So the psychosocial burden and the fear, the anxiety of the impending death is reduced to the patients. Then other occult research which can be detected as when you do a CT scan, it scans from approximately neck to the upper abdomen. So other things like thyroid nodule can be picked up, some pulmonary artery hypertension, then aortic aneurysms, and renal cell carcinoma of the upper pole of kidney, and breast cancer can also be identified by using this low-dose CT scan. The challenges in India and low middle income countries are sometimes it can be false positive and the fear of radiation exposure, then the cost of the scan. The imaging techniques which we use to look for tumors in lung are the basic investigations like chest X-ray, then CT scan, PET scan. Then for metastasis, when one cancer of one part goes into another part of the body, that is known as metastasis. To find out that, we have the diagnostic modalities like MRI and bone scan. So the first and foremost investigation which the pulmonologists order is an X-ray, which is used to check for a suspicious mass in the lung. And chest X-ray findings suggestive of lung cancer, then we have to go for the further tests like CT scan and all. The second one is CT scan, which provides the information about the primary tumor. Then CT scan captures a series of cross-sectional X-ray images, and CT findings help to determine the additional imaging is needed and the guide choice for the optimal site for tissue sampling of pathology, particularly in regional lymph nodes. So whenever a patient is suspected to have a cancer, for starting the treatment, there should be a tissue diagnosis. So the CT scan helps to provide the tissue diagnosis, the location where to go and take the biopsy. The next one is the PET scan. The PET scan uses a radioactive molecule injected into the blood to detect rapidly growing cancer cells. So this helps to identify the cancer and also the metastasis, because the PET scan, usually we do a whole body PET scan. So it screens from the head to toe. Then, as I earlier specified, MRI is generally used to screen for brain or spinal metastasis. Then bone scan also used to screen the metastasis, which are going into the bone. Now, coming to the sampling techniques. The sampling enables the isolation of tumor tissue for further examination and classification into the subtypes. The first one is a tissue biopsy, and second is liquid biopsy. The tissue biopsy can be done through bronchoscopy or FNAC or any other modalities like EBUS, then thoracoscopy, mediastinoscopy, etc. That will be coming into the subsequent slide. And liquid biopsy is the blood sample analysis to enable the molecular analysis of the DNA of the cancer phenotype. The simple method, first one is a sputum collection to examine for the malignant cells. The problem in this is it requires an experienced pathologist, or there should be enough malignant cells to identify in the sputum. So this one is a challenging examination, but if there is a good pathologist is available, and if the cells has got some malignant cell, then the doctor can pick up as a case of malignancy. Then next is a bronchoscopy, which the pulmonologists usually do. This is a simple technique using a fiber optic bronchoscope, either through the nose or the mouth. It will go into the lungs, and depending on the CT scan finding, the location we know, and we go there and we take either the FNAC, TBNA, or the biopsy. Then second is the needle biopsy. This is image guided. So whenever the lesion is in the central part of the lung, the bronchoscopy, whenever there is an endobronchial lesion, the bronchoscopically the biopsy can be taken. But if the lesion is in the periphery of the lung, the bronchoscope may not be able to reach that point. So we ask the help of the interventional radiologist or the radiologist to take an FNAC or a true cut biopsy from the sample. So this is the needle biopsy to remove tissue samples for analysis. Next one is a thoracosynthesis to remove excess fluid for analysis. So the basic of basically the patient who are having malignancy, they develop pleural effusion. So whenever there is a pleural effusion means the fluid in the pleura. So we can do a pleurosynthesis and do a analysis, or a thoracosynthesis. Then this malignant pleural effusion fluid can be sent for cytology or a cell block, so that we get the malignant cells, and the treatment can be started. The second one, the next one is the endobronchial ultrasound. The thing is, the an ultrasound image technique where we go through the mouth to the mediastinum. So whenever a patient is having cancer, sometimes they may have a metastasis to the mediastinal lymph nodes. So we go through the mouth and we, with the probe, go in and take the tissue sample. We can do biopsy, we can do TBNA. Two things which we can do through the EBS. And next one is US, which use an endoscope fitted with an ultrasound probe, which pass into the esophagus. Instead of going into the lung, we go into the esophagus, and the stations of lymph nodes are identified and take biopsy. The next one is the mediastinoscopy or mediastronomy. In that, what we do is we make an incision over the neck, and with the scope we go into the mediastinum and take the biopsy. So coming to the physicians play an important role in early lung cancer detection. You can see the physician can certainly help in improving detection rate by being more alert, especially in patients with respiratory symptoms not responding to antibiotics, who are chronic smokers, if there is a family history of lung cancer, and the patient, the doctor should be cautious of reading chest X-ray. What happens, sometimes in the periphery, when you see a small lesion, they start the treatment as tuberculosis without further advancing or without doing any investigations. Because in India, the burden of tuberculosis is very much, so they start like that. So that's a pitfall which the general physician should remember. And now the screening to identify the suspicious nodule. So whenever we see a nodule in the lung, either through CT scan or PET scan, if the size is 5 mm or smaller, then the follow-up is for 12 months. So they have to take a CT scan in 12 months. Likewise, 6 to 7, 6 months, 8 to 14, 3 months, and 15 mm or more, a chest CT scan and a PET scan is recommended. So early treatment will lead to better survival. In this slide, you can see, as per the previous speakers told, the mortality increases as the stage advances. You can see the last stage, the 5 years survival in stage 1B is less than 1%. And if you detect the cancer early, then you can see the survival is 92%. As the previous speakers told, 77 to 92% survival of 5-year mortality is there if you can identify the lung cancer in the stage 1. Issues with lung cancer screening. There is no screening guidelines for non-smokers. That's one of the problems. We have to develop screening guidelines for non-smokers. Physicians need to be more alert when encountering patients with respiratory symptoms, especially in non-smokers. Then low-dose CT scan is more costly than chest X-ray. Chest X-ray is has very low pickup rate. So X-ray with artificial intelligence, like in the previous lecture we must have heard about the artificial intelligence. So X-ray can be combined with artificial intelligence for better diagnosis. So what is the solution for lack of screening in high-risk patient? We have to make robust guidelines. In India, there is no guideline for doing screening for lung cancer patients. So there should be a robust screening guidelines. Each institution should have its own screening programs till a national screening guidelines is formulated. Physicians should be aware of patients they can refer for lung cancer screening. So doctors should know that they can refer, if they are suspecting a lung cancer, they have to refer the patient for screening. These are the screening guidelines of US by NCCN. In the high-risk group, like radiation exposure, smoking history, cancer history, occupational exposure, COPD, then the guidelines of NCCN says, the group 1, the smoking cessation less than 50 years, even though it is there. If the package smoking is more than 30 and age 55 above, there should be undergoing a screening. And in the group 2, age is more than 50 and the package of cigarette is 20. They have to go for screening. Unfortunately, for moderate and low risk patient, there is no guidelines by NCCN. These are other guidelines for lung cancer screening. Out of that, one of the latest is 2021 by US Preventive Force, which is followed in almost all the countries like Australia and all. This says the recommendation of annual low dose CT scan is age between 50 to 80 years. So the age of the patient is above 50 and less than 80, and he is having a history of 20 pack years. I hope everybody knows the pack year concept. It's like taking a pack of cigarette which is having 20 for 10 years. It's like that. Or 40 cigarettes in 10 years every day. So that is the pack year. So if it is 20 pack years and age between 50 to 80 and a patient who is a current smoker or quit smoking for the last 15 years, he has to undergo the screening. That is the current guidelines which are followed by other countries. So creating our awareness among general public is very important. In India, so many organizations are there to create awareness among general public. Finally, the last slide, the way forward. There should be institutional program that each institution can have its own screening programs till a national screening guidelines is formulated. Artificial intelligence-based technologies on CT images to detect incidental nodules can be provided because AI have got better than human eye. Next is a tobacco cessation or smoking cessation. We have to educate the people and tell them that the patient should be aware about the risk of smoking. Individualized screening can be done. Each case should be screened as per the presence of risk factors. So by following this and formulating a screening guideline, we can try to reduce the burden of lung cancer. With this, I conclude my talk. Thank you so much for the patient listening.
I would now like to invite on stage Dr. Anant Mohan, Professor and Head Department of Pulmonary Critical Care and Sleep Medicine, AIIMS, New Delhi. He will discuss with Colonel Dr. Shafeen Babu on his presentation on the suggestions made for screening for early detection of lung cancer.
Thank you very much, and I think thank you to the organizers for inviting for this very important session, and also thank you, Dr. Shafeen Babu, for taking us through the entire gamut of lung cancer, starting from how the symptoms evolve, how to suspect, how to diagnose, what are the diagnostic tools we have, how to suspect early, and then of course why it is important, the burden of disease, why it is important to pick up early. What are the tools for screening, and then of course the challenges. So I think all of these have been covered very nicely. Just to, I won't, without repeating anything that he said, what I want to emphasize is that it is not just the numbers of disease which is important. So lung cancer of course is on the rise, and in one of the slides you must have seen around 88,000 cases per year about 1 or 2 years back. It is the fatality rate which is very important. Fatality rate means that if untreated, the almost 85 to 90% of the patients which actually die within 1 year, if not more. So the fatality rate is very important. If there is some other cancers, for example, prostate cancer, etc., if picked up early, then they have a very good survival, but not so with lung cancer. That is one. And then, of course, all the challenges which are there regarding. So we'll stick to the early diagnosis and screening. Now, the concept of screening for lung cancer came up almost 40-50 years back, and that started with what the list Dr. Babu showed with sputum cytology. It did not work, unfortunately. Then there was X-rays as an early pickup tool, and then there were mega trials, actually, the Mayo Clinic trial. There was the Memorial Sloan Kettering trial. There was the UK PLCO trial. So these were the trials which looked at X-ray. Somehow they also did not work because the end point kept was reduction in the mortality. So that was not achieved. And then many other things were tried, and then finally in 2011 the National Lung Screening Trial came up, and from there the low-dose CT has been now currently it is supposed to be one of the good ones. Now of course that has its own challenges, and we'll discuss that right now. Among the newer modalities, we definitely need more newer modalities, maybe more non-invasive, cheaper, more easy to implement, and more reliable. And some of them, for example, the electronic nose, the breath print, and all these things which you have said, they are still experimental, but I'd just like to share with you that we are doing some of that work at our place. We have a Center for Excellence in this by ICMR. So we are looking at the last 5 years electronic nose and breathomics. We have some interesting results, and some of them have been published as well. Another important thing which I want to emphasize again for the general practitioners and physicians, that early pickup is when you suspect early. So as one of the papers you already showed, we had published that tuberculosis faulty diagnosis leads to a delay of almost 3 months. So somebody in the periphery sees a shadow, patient has fever, hemoptysis or cough, they will start anti-tubercular therapy, and ultimately it turns out to be a lung cancer, and this leads to a delay of almost 3 months in the diagnosis by the time the cancer has spread. So that is also important, the level of awareness. So I think with these words, I think I'll just kind of again thank you for your lecture, and one question from my side, and then I'll also ask the audience for this thing. So you have told a number of tools for lung cancer screening. So out of those, which one do you think appears to be the one or two most promising ones given our setup at this point of time?
Sir, at this point of time, the gold standard is low-dose CT scan, sir. That is the gold standard. Apart from the newer modalities, like electronic nose, which you told, and breath print analysis. These are very non-invasive and the cost effective. If you see the PET scan or other investigations like autofluorescence bronchoscopy or something like that, then the cost effectiveness is not there. So the easiest, apart from the low-dose CT, is a ENOS or a breath print analysis, what I feel is. But in India, it has not been approved till now. And the two eminent things which I have done for ENOS, one is by the All India Institute of Medical Science under Dr. Anant Mohan sir. The ENOS is there and it has showing very good data. But it requires RCT. Another is done by a engineer, Binson. I think Binson. So he's from South India. He has done the same thing for ENOS. So their studies shows that it is non-invasive, as well as it can differentiate the types of cancers, like non-small cell from the small cell. And sometimes some techniques of ENOS can diagnose COPD and asthma also. So these are the promising and upcoming non-invasive techniques to screen lung cancer. Still, we require more of RCTs, sir.
Yeah, thank you. So sticking with lung cancer screening, so again I would like to share that we did a little bit of work on this since we have been doing a little bit on for the last couple of years. So we looked at, in TV we looked at this AI. There was a very interesting talk just before this about AI and X-rays for lung cancer, which is very interesting, and we are conducting an ICMR multicentric trial on AI and X-ray for TB. So among those also we are now in they are in the process of collecting data. Let's see what we get. But as far as this AI for lung cancer is concerned, I would actually encourage the authors and the people who are conducting that if they are finding results, they should publish. So if possible, they should publish the results. The reason being that we talk about government policies, which of course is, unless something comes from the government as a policy, it will not be implemented. But knowing them, unless we show them data and evidence, no policy will come up. Yeah, so I think for whatever work is being done, excellent work is being done, and I think it is very important to show it, publish it in peer-reviewed journals, and once the strong evidence is there, then we show it to the people who can generate the policies also. So that is one. Among lung cancer screening, low-dose CT, which you are talking about, we are doing 2 theses in our department, in which we are looking at annual LD CT in our patients, which are high risk. Right now, I don't think it is very, very reasonable to do low-dose CT in asymptomatic across the board population because of financial and other resources, logistic in our country. But we are looking at in the high-risk population, like you mentioned, smokers, biomass exposure, elderly age group, etc. So again, we are getting encouraging results. It was felt the earlier trials, the National Lung Cancer Screening Trial, which you showed, had some problems. In fact, it had several problems actually. One, the high false positivity rate was there. 95% high false positive rate was there. So the 95% of the abnormal CTs actually did not have lung cancer. They had something else. But they picked up lung cancer nonetheless. So whether it was TB, in our country, every second person has TB. They will have some scar in the lungs because of TB. It was felt, will that hamper the results of LDCT? That was a kind of a fear. So what we found so far is that probably not. It will not hamper. It is possible to do low-dose CT screening in our high-risk population. So that is one thing. So anything from the audience? I think we'll have some questions from the audience, if anything. Otherwise, we can go on. Yeah, sir, please.
On very economic means of detecting early stage lung cancer, because most of our patients, I as a surgeon know, come at a very late stage and where we cannot help these patients. And I think integration of AI, as sir pointed out, is a very promising tool, because chest X-ray can be very easily managed, and if it can be validated that it is helping, because the previous trials did not validate X-ray as a modality for screening for lung cancer. But with the presence of AI, if it can be validated that it can help us, I think incorporation of that might be much easier at a mass level compared to LDCT. So I think I just wanted to make that comment too.
Thank you. That's the point well taken. Any other questions, any comments from anybody regarding diagnostic, screening? Yeah, please. I think the people to answer that question will be the AI experts. What I mean to say, what it means is that if there is any abnormality which is picked up, so it becomes very sensitive. It will pick up an abnormality, but whether it will pick up the abnormality that we want, that is going to be the problem. So there may be 100 people in which abnormality is there, but 95 of them is not lung cancer. So only 5%. So that is going to be the problem. And what happens is, because of those scars and abnormality, you go in and do more investigations because you want to come to a diagnosis. So that investigation, more CT scans, PET scans, surgeries, biopsies. So all that was the problem, and that is why it is not so easy to do low-dose CT. You know, it is very easy to say, but when it comes to the practical aspect, so I'm sure Dr. Bilal will agree with me. So suppose he's getting flooded with people, with patients referred by us, you know, कि इसको यहाँ पे कोई mass आया, इसको please prove to us that this is not lung cancer. How can you prove? So, you know, these are the problems that will happen. So these are the other side of the story, which, you know, we have to also keep in mind. Dr. Babu, one question.
Just a minute. Yeah, this side. It is not a false positive, but a false negative will be more critical over here. Because so newer technologies, the way we have, what you pointed out on having the clinical data, supporting clinical data. So if with the newer technologies we are having a false negatives, that will be the huge
false
problem.
Positive and negative will create problem. If it is false negative or positive, one
a dependency on the technology.
Yeah.
And technology is saying it is a false negative, then it is a problem, not a false positive.
So false negative means that we miss a diagnosis.
Yes.
Okay, so that is true. So both the things are important. False positive means that a CT will say that something is there, and then we chase it, and ultimately it is not what we want. So that is also not desirable in a screening program, because there we are subjecting lakhs and lakhs of people to this. So that means lakhs of people will be subjected to more and more investigation. Out of that, only a small percentage will have the disease, others will not have a disease. So that is the problem. Of course, false negative is also a problem, because we miss the actual diagnosis. Yeah.
So one question you were asking.
I was just asking you that from the bigger perspective, how do you sensitize the GP? This empirical anti-tubercular therapy, early suspicion. So what are the ways towards that to prevent all these things?
Sir, two things there regarding the lung cancer screening and the diagnosis and treatment. The first one is what we say is the patient barriers, and second is the screening providers or the doctors. So the patient perspective, there is a lack of awareness in Indian population. There is a fear of cancer diagnosis, like I am how diagnosed to be a case of cancer, and the perceived stigma of discrimination in the society as a cancer patient. Then if you offer some screening technique, then the cost concerns. All Indians are not rich. Almost all are middle or low income. Then the lack of motivation. And the most important thing is the feeling of healthy. Sometimes what happens, patient may have cancer, but they don't have any symptoms. So these are the patient barriers. And coming to your question, sir, the general practitioners and all. So the general practitioners should diagnose the case according to the good clinical history, clinical examination. So clinically, we have to be sure that yes, this is tuberculosis, not cancer. Second thing, the radiology. In that radiology, only chest X-ray should not be done. But in periphery, you may say that we don't have any CT scan facility. We have only X-ray. So the doctor should think after giving ADT for 2 months or 3 months maximum, patient is not improving. Generally what happens, the intensive phase of 2 months with HRZD medication, the patient should improve. If the patient is not improving, some doctors says like this will take 6 months or 9 months. You have a disseminated TB. That means not only in the lung, you have some nodule over here, there and all. So the disseminated TB takes 9 months. I get patients from the periphery of Calcutta with cancer, as a case of cancer, diagnosed by me, but diagnosed by other doctors as tuberculosis and treated for 6 to 9 months. So the valuable time is lost. So whenever the patient is not improving, the general practitioner should think, is it anything else? And he should refer the patient to a higher center. If he doesn't have any CT scan or something like that, then the district hospital or the medical college will definitely have the facility. And if you tell the patient, I suspect something else, then everybody is afraid of life. So they will somehow make the way out to do the next step of diagnosis. So that's what the general practitioner should do. And secondly, the insufficient time of the doctors or insufficient knowledge to discuss the thing or discuss the case in toto. Sometimes the OPD may be busy. So they may not have the time to discuss the patient or discuss with the relative about the problem. Then there is no proper screening guidelines in India. The unfamiliarity or the difficulty to identify the eligible patient. These all are the things which are happening in India, and that is the reason why lung cancer is treated as tuberculosis, sir.
Right. So last question, if I think just because of shortage of time also. So we have a question there, yeah.
Lung ultrasound generally not, because the thing is it can pick up the consolidations and all, but the mass is difficult. But lung ultrasound can pick up pleural effusion, and you can do a cell block with the diagnostic fluorosynthesis. Remove the fluid from the pleura and make a cell block and send it to the pathologist. So if it is a malignant pleural effusion, we can diagnose. So in that way, we can diagnose even TB or malignancy. Both can be diagnosed by a cell block or simple cytology. Sometimes you can see if it is the pleural fluid has got n number of malignant cell with single microscopic examination, you can pick up the malignancy. So ultrasound will help for that, not for the mass lesion.
Any point of care testing in the pipeline, like now in detection of breast cancer, you have these lot of non-ionizing radiation in picking up these hot nodules in the breast. So anything of that?
See, this all that I told, autofluorescence bronchoscopy, like that, so many are there in the pipeline. And for the pulmonologists, the established one is known as lung point. That is, with the help of CT and AI, the AI says this is the place where you have to go and hit. So that is a lung point where it is easy for the doctor to take a biopsy. And the newer modalities like radial EBUS, just endobronchial ultrasound, which we told, like that, the newer modality is a radial EBUS saying for the nodule, yes, this is the area which you have to go. Otherwise, all other modalities are in the pipeline. And the easiest and non-invasive is either the breath analysis test or the ENOS, which has been developed by All India Institute of Medical Science.
So I think just to clarify the point, see, we should not confuse screening with diagnosis. Screening is a different thing, diagnosis is a different thing. Diagnosis occurs in a person who is symptomatic. Screening occurs in a person who is not symptomatic. So diagnosis, for that we have several tools available, which is already enumerated. We have all kinds of minimally invasive tools, radial EBUS, navigation. We have everything to even go to small nodules inside and access. All that is there. But that is in a symptomatic patient for diagnostic purpose. For screening purpose, we can't. When screening, we are talking about mass level, population level. For that, to answer your question simply, we do not have a single point of care test for screening for lung cancer as of now. We don't have. The only thing which is right now available, which is being promoted, is low-dose CT scan, which and X-ray with AI. I don't know if they have got good results. Excellent, then it should be kind of shown, and if possible compared with other modalities, that which is better. Then that will give the actual results. So that is where we stand now.
Sir, I have a very, may I?
Yeah.
So my name is Vandana, and I am with Lung Connect India Foundation. We are a patient support group. Sir, you mentioning about screening. My question is very basic. We have a lot of patients who come from rural India, where, like Dr. Babu said, the diagnosis is delayed. How do we encourage the public health centers or the physicians that they see the first time to say after 15 days if the patient is not feeling better? How do we encourage these physicians? Because a lot of times there's a delay in diagnosis because of delayed referrals. How can we ensure that, sir?
So actually, that again, I can quote our own publication to that. The delay in referral is there right from the time the patient gets a symptom to the time he goes to the first doctor. Then from the time the doctor sees to the time the diagnosis is made. So all these are delays, I fully agree. The only thing is just continued education of the physician, continuous. It's a continuous process. It has to percolate down to the PHC level. We are sitting here talking in a very small audience and gathering, but we have to take this down to that level that if you start anti-tubercular therapy, then you must monitor weekly, 2 weekly, and there should be a time when you feel, okay, he's not improving, then think of other things and evaluate further.
Right. So, and I think it's also important to tell the patients, because sometimes,
of course.
To tell them if you're not getting better, you need to come back.
Absolutely.
Yeah. So thank you.
Okay, I think she's been asking for quite some time. Yeah, please.
They get some various type of symptoms which confuses them. So would you like to address some common symptoms that if one person is having regarding this lung cancer only, like?
So yeah, see, nobody can stop anybody from Googling. Is it the only good thing is that in respiratory medicine related to lung cancer there are only 4 or 5 symptoms by and large. So there will be cough, there may be sputum coming, there may be breathing difficulty, chest pain, or a bit of blood coming out in the sputum. These are the 5 most common symptoms of respiratory medicine, including lung cancer.
The thing is, those who are smokers, they know they are at a potential of this, getting a lung cancer, and they Google and they know that they should go to the doctor. But those who are in their family, who are like passive smokers, who are like at the greater risk. So that's what how do you want to address them that they should keep this?
Only mass education programs. Yeah. The only way is to educate them, no?
Is there any like very common symptom which is like,
if there is blood and sputum, that this is probably the most dangerous symptom out of all these.
Okay, because it's usually taken it as like tuberculosis.
I think you'll agree. Hemoptysis will
yes,
be probably.
Yes, hemoptysis is one of the short thing for cancer, and the second DD should be tuberculosis. The commonest is like persistent cough. Persistent cough means more than approximately 2 months, which is not getting treated with normal medication. This also is a DD for lung cancer and tuberculosis.
Last question, I think. Yeah, last, please.
Hello. So my question to you is based on understanding. I am unable to understand that how will such guidelines on screening will going to help us on early diagnosis, because if such guidelines are implemented that we have to smoke this number of cigarettes to know that okay, we are eligible for getting screening, or there are yet other factors as well, like aging, pollutants, carcinogenic agents where we live in. So how is it going to help us? Yeah, that's it.
So actually, in the presentation, I have shown the risk factors like exposure to the pollutions that you have seen. And this guidelines is not of India. The 20 package concept is of Western countries.
Yeah, okay. This was just an example.
Yeah. And why they are doing this cutoff of this package and all? Because the smokers who have smoked more than 20 packages are at high risk to develop cancer. Understand? That's why they are doing this cutoffs. That's your question, na? And
so how do we know that we are eligible if such guidelines are implemented?
So just count the cigarettes which we have smoked.
Just cigarettes, because there are other factors
and the other
as
thing,
well.
like if a patient is smoking for the 15 years as per the guidelines, or that 15 years cutoff is within that day. Okay, the criteria to stop screening is age above 80, and once you are out of that 15 years smoking level. Like today, to the last previous 15 years, if at all I was smoking, I am eligible today. But I have stopped smoking 15 years back, and tomorrow I am out of that cutoff. You got my point? And the third criteria to stop screening is the poor life expectancy or inoperable cases. Like in some patients, we can say that the life expectancy is not that much, so don't have to screen him. Understand? So these all are depending on the patient and doctor, and it is different for different individuals.
Let me also add to that all these criteria have been made because the trial which was done, the NSLT trial, they use these criteria. Now, when you design a trial, you have to have some very strict objective criteria if you want it published in a very high impact journal like the NEGM. So that is what they did. Now, that doesn't mean that if the criteria is of 20 pack years, then 21 is not eligible or 19 is not eligible. Practically, it doesn't mean. They are guidelines to help guide. So guidelines have to have some approximate, something to help out. That doesn't mean on a case-to-case basis you cannot do it for others. But when you are doing something on a population scale, then you have to set some criteria. Otherwise, it will become, vague. So I think these are the reasons why these criteria are there, objective criteria, especially in India. Unless we give some criteria, then we are very fond of guidelines in our country also. What are the guidelines for this, that, everything. 120/80 is the BP guideline, something like. So something has to be there, but this is not absolute. one has to kind of take it in the proper perspective.
Like you journalists ask now, what is the evidence? What is the guidelines? You, doctor, you have done this.
So these days the commonest question to us is, have you witnessed an increase in your patients because of the pollution, and what is the percentage of increase you have witnessed? So none of us know the answer to that question, but now we have learned to say 20%. So, okay. So thank you so much.
Thank you all. Thank you.
Thank you to both our doctors, Dr. Anant Mohan and Dr. Shafeen Babu. I would request Kamal to please come up on stage and present Dr. Anant Mohan with a memento. Thank you so much for more analysis on the presentation made by Colonel Dr. Shafeen Babu, and of course giving us clarity on how guidelines are given for screening. Please give a round of applause to Dr. Anant Mohan and Dr. Shafeen Babu. Now, so far we have spoken about imaging and AI's application, screening, etc. Our next presentation is going to be on the role of biomarkers as advanced diagnostic tools. Molecular biomarkers such as genetic mutations, example EGFR, KRAS, and protein expressions can provide critical insights into tumor biology, enabling personalized and timely interventions. By integrating these cutting-edge technologies into routine diagnostics, clinicians can identify high-risk individuals, tailor-make treatment strategies, and reduce the overall burden of lung cancer. So for this presentation, I would like to invite on stage Dr. Charu Bahal, Senior Manager, Scientific Affairs Manager at MedGenome Labs. So please give a round of applause and welcome Dr. Charu Bahal on stage.
So very good afternoon to all the dignitaries. Thank you so much, AstraZeneca and IHW to invite us here. So today I'll just be taking you through role of molecular biomarkers as an advanced diagnostic tool in lung cancer. So I think, as we know, lung cancer is one of the most commonest cancer. The load of lung cancer has been really explained in the previous lectures. The important thing is to decrease the current poor overall survival of the patients with lung cancer, and the detection of the disease early when it can be curative, intended by surgery or radiotherapy. So basically, diagnosis at an early stage increases the 5-year survival rate to 56% as compared to just 5% for the late stages. So if I look at the discovery and development of the biomarkers for early cancer detection, till date, from the 20th century, there was only blood-based composition changes. Concept of biomarker was introduced. From 1940s to 50s, there was early discovery like pap smear as a screening tool was instituted. So this is around the general cancer concept. And further, there was advances in the technology where electron microscopy and immunohistochemistry emerged. And in the 1980s and 90s, the genetic and the molecular markers came up, where you have genetic tests being developed and genetic screening programs such as BRCA1, BRCA2 for other cancers like breast and ovarian, and then prostate cancer was PSA for prostate cancer. Now, in the 20,000s and the coming years, the round years, liquid biopsy is as a technique has emerged, and panels that combine multiple biomarkers have improved the accuracy of these panels. Till date, I think the low-dose CT has been really discussed in detail. So definitely, it increases as compared to X-ray. It has better sensitivity, but has a high false positive rate. So other than that, we need to look for markers. We need to look for approaches for early screening. So tumor biopsy has been the gold standard. It detects the protein markers, which are identifiers that a cell a lung cell has turned into a malignant cell, which is CEA or SCC or NSC. However, it is invasive, and the nodule or the mass has to be located on a CT before you do a tumor biopsy. So counter to that, we have a technique coming up of liquid biopsy, which is to use the normal blood, just a blood draw, and that has emerged as a promising tool to detect tumor biomarkers in the bodily fluids in a non-invasive manner. So they show that they have a role to play in lung cancer screening, diagnosis, and monitoring, and they improve the patient prognosis. So if we look at the multi-marker analytes that you find in a liquid biopsy sample, in an event which starts from cancer screening to the refractory cancer, depending upon the treatment strategy, a blood sample will have all these different fragments. Like it will have cell-free DNA, which is the DNA being leached out from the tumor cells and the normal cells. Then you have exosomes, and then you have circulating tumor cells, which are the cells itself which are streaming in the blood if there is a tumor being formed, and it starts to metastasize. So when we evaluate these three fragments differently, the cell-free DNA, you can put it to various technologies to detect point mutations, which are indicative of biomarkers having these mutations, which are primary drivers for MET exon 14 skipping mutation, or there is a amplification of a EGFR gene, or there is any other such related copy number variation, which can indicate the presence of lung cancer. Then you have CTCs. So CTCs are basically the cells which are traveling from one place to the other in the normal bloodstream. You have multiple DNA abnormalities that you can detect in the CTCs. For that, you have to obviously isolate the CTCs and find out what is the RNA profile in them. So for these, you generally use single cell sequencing also, which is you have to sequence the genetic material from the single cell. So these are all the nuances which are being developed these days to detect lung cancer through liquid biopsy, maybe at an early stage where there are screening tests which are being approved right now and which are not available in India, but I think all around world they are still available. They are coming up. They are very newly introduced. But for localized cancer, for metastatic cancer, and for refractory cancers, liquid biopsy as a technology is quite well established now. So these are just the list of a few trials which are going on to use the different biomarkers in serum, plasma, microRNA, DNA methylation profile, to determine when you have a diagnosis of indeterminate nodule. So there are two categories. One is the diagnosis of the indeterminate nodule, and other one is the risk or mass screening. So in all those categories, there are different trials that are going on using serum plasma markers, using tumor or other markers like chromosomal aberrations, SNPs, mRNA expressions, and even at the sputum, breath, and urine level, we can detect DNA methylation, we can detect tumor cells, and then that is how we are developing all these technologies are being developed these days. So ctDNA as a marker in the clinical practice, it basically helps you to identify and also monitor the disease, and also find out if it is an advanced lung cancer case, whether there are any, whether the disease is going to recur, or whether the disease is recurring because of a certain new driver mutation that has come up. So in a way, it provides you that molecular diagnosis, provides you better prognosis, and you can tailor-made your therapy as per that. So there are various oncogenic drivers that have been reported specifically in non-small cell lung cancer. I think we all are well aware of it. The treatment, it's like lung cancer is a model child for targeted therapies. We have immense number of targeted therapies that are available. And as more we are doing the testing, we are getting new and new mutations being reported. The only thing is to correlate these mutations with the clinical outcomes and produce Indian level-based data so that we can provide better, better facility, and we can also provide better testing methods to to our Indian patients as per their genetic etiology. Because all of these data which is available right now is from the Western countries. So role of biomarkers in early stage, specifically in Asia, mostly EGFR and PD-L1 are the two biomarkers which are generally being used in patients who have non-metastatic non-small cell lung cancer. So if we look at the detection of early stage cancer, it's very, very low, particularly in India, but there is a lot of heterogeneity. If you see in Japan, 40% of the newly diagnosed lung cancer cases are stage 1, so which is quite a good number. But in India, it's not that. We very well know that. So mutation-based testing and PD-L1-based testing can definitely help in giving better treatment, tailor-made treatment to the early stage cancer patients as well. So these are just the new upcoming biomarkers we have in advanced non-small cell lung cancer. Be it ALK, EGFR, all of these are established, but there are some emerging markers which are coming up, something like STK11, MAPK21, PIK3CA. We might not have therapies available for each one of them, but they do have an implication in selecting the therapies. If it is an EGFR mutated patient with a PIK3CA mutation, then obviously the response of the patient is not going to be as a EGFR only mutated patient, because PIK3CA will be a co-driver and it will subside the response of EGFR TKI. So those kind of nuances are very important these days because they greatly impact the PFS of a patient when they are showing a recurrence. So this is just an example of concurrent mutation which we have identified at MedGenome, one of the cases. 47-year-old maid with adenocarcinoma of lung with pleural biopsy was taken. So we have done a lung panel and we have got a EGFR exon 19 deletion, but alongside we have also got a FGFR3 fusion, which is a rare event because FGFR3 generally is a acquired resistance mechanism which develops when the patient has already been treated on EGFR. So this is like an intrinsic mechanism where the patient had this clone at the time of diagnosis. So it greatly impacts the efficacy of EGFR treatment. And this is basically the clonal genetic heterogeneity of non-small cell lung cancer, which is now being identified because we have, escalated the kind of testing we are doing. We have broadened the panels, and whenever we are doing the testings, the kind of technology we are using, the platform being used, that highly implicates on the kind of mutations and alterations we detect. So liquid biopsy and tissue biopsy, I think, has been well explained also, but just to give you a greater idea, in the early stages, the cfDNA fragments are lesser, but when there is a relapse, the amount of cfDNA is obviously going to increase, which we can detect through profiling. There are some very good studies which have been published where you have a great concordance of liquid biopsy and tissue biopsy. So I think there is quite a good need to have a good acceptance of using both these technologies in terms of rationalizing the patient's outcome. So when we say we have failed on the tissue level, we don't want to go with liquid biopsy because we are not quite confident yet there. I think the time is out there now. Most of the companies have, or most of the testing facilities have established that concordance, and they are using that level of technology right there in India to go to that level. So this is just an example of liquid biopsy where we detected ROS1 fusion through liquid biopsy, and basically patient was negative for EGFR mutation by RT-PCR, and no other test was done at the time of diagnosis. So you can see the partial response that was observed after a few months using the therapy based off or the test. Similarly, we can identify drug resistance mechanism. So this is another example where we identified a ROS1 fusion. Alongside, we also identified a ROS1 point mutation, which was basically implicating the resistance to the ROS1 inhibitor. So ESMO 2022 guidelines also give a great indication on using liquid biopsy as a complementary testing. in treatment invasive and disease relapse condition, wherever you can miss histopathological examination, wherever tissue biopsy is to be preferred for fusions and gains, and most cancer types ctDNA testing if the tissue is not available. So this is the updates from the ISMO. So similarly, we also do monitoring using liquid biopsy. This is a patient being tested 3 times, and we have seen the marker like ALK-EML4 fusion, the percentage or you can say the number of copies of that marker. When the patient had relapsed again in 2024, the same mutation had come back with 591 reads. So this is just our internal comparison of 98 patients where we have used both liquid and solid liquid biopsy, and we have found good number of mutation in terms of you can say the RET, the exon 4, the MET skipping mutation, also the KRAS and NRAS have been found. So this is just a map of however whatever results we are getting at our center. So the current scenario, obviously with the increased number of genes, comprehensive profiling, either tissue or liquid, is becoming much more efficient method, which can provide you initial assessment. Obviously there is a need to optimize the turnaround times, and we have to also be very careful about the tissue, because that is the major issue in lung cancer. Key takeaways while developing biomarkers in early diagnosis is heterogeneity and complexity. As I have shown you, the lung cancer is highly complex. There are a lot of heterogeneity in the tissue, in the lung cancer profiling that happens. There has to be standard assays and platforms which can provide those protocols. There has to be clinical relevance and utility of those biomarkers. Validation has to be done in diverse patient population, because we know India is a very diverse country. And integrative data analysis and machine learning is the need of the hour, without which we can't manage and understand such data, which we create or which we analyze. And regulatory approval and clinical adoption. So these are the important things which we can take forward from developing biomarkers in early diagnosis in case of lung cancer. Thank you so much for your patient listening.
Thank you so much for your presentation, Dr. Charu. Well, surely this is a new frontier and something that I think is better understood by the medical community. But the process seems very simple. And I mean, at least for a common man, if something like this could help tailor the treatment better, nothing could help him more. So I'm going to call on stage Dr. Maushami Suryavanshi, Senior Consultant and Head, Molecular Biology and Cytogenetics, to please come up on stage for the moderation of this discussion and to discuss the role of biomarkers in detail when it comes to the diagnosis of lung cancer. So would request both of you to take a seat, and we'll give you the hand mics, and then we can start with this discussion.
Good afternoon, everybody. First of all, I'd like to thank IHW for this invite and also for organizing this event. More so in Delhi, and even more so in this time of the year, and this time, this day also, because the AQI in Delhi has shifted from very, very, very bad to bad. So I think we are all receptive, and this is one of the causes of lung cancer. Pollution is a big cause. We have always been talking here about the smokers, but the non-smokers, the numbers are rising. And in fact, nobody talked about that. Women are also, lot of women numbers are rising for lung cancer. And this pollution and the house smoke is also a reason. And as Dr. Charu has already told us, we do molecular, and she's very well elicited the role of molecular and where it is going. So basically, just to bring everybody on the same platform, so what is molecular? So we all have DNA, and which is a normal DNA. And when you have cancer, there is something which is not like the normal or not like the normal variation. So these are called mutations, and these mutations are what they are red. And lung cancer is the poster boy of molecular. So it is very important. Why so? Because we have a lot of mutations. There are a lot of mutations in other cancers also, but this particular cancer have lot of mutations which match with the drugs. Drugs which are not chemotherapy, but they are molecular therapies. They are usually like a tablet. So you are having a stage 4 cancer and taking a tablet and having a normal life. So that is the revolution molecular has brought to lung cancer. And more so what Dr. Charu just talked about was about liquid biopsy. That is another revolution. So as she has mentioned, that it is just a drop of blood or maybe a urine or maybe CSF or pleural fluid, any bodily fluid, which could be a source of tumor. So that tumor can be a complete cell, as she mentioned, the circulating tumor cell. So which are the tumor cells which have shed from the main tumor into the blood or urine or whatever, or it could be a fragment of that DNA. So all cells are destined to die, and when they die, the DNA of our DNA breaks, and as it breaks, it comes into the circulation, and that is what is picked up by these super sensitive machines and those mutations for which there is already a drug. So that is the importance of these technologies and this kind of revolution which has come to it. So, okay, do you need water? Can we have water? So this is pollution. You can see, in fact, I was sitting in the hall, there were many people coughing. Yeah, please. So this is because of pollution, and today that is why I rightly said that this is the topic we are discussing. So it's okay. So there are two things I would just like to ask you, Dr. Charu. One is a tissue biopsy and one is a liquid biopsy. So your main talk was about liquid biopsy. So when do we use tissue biopsy and when do we use liquid biopsy?
So I think there are various scenarios. Obviously, tissue biopsy is the gold standard to establish the diagnosis. Right now, liquid biopsy doesn't give us the leverage to establish the diagnosis. But liquid biopsy can help in early screening, which is by levels of ctDNA or detection of CTCs in the blood. The second thing is liquid biopsy helps you in profiling the molecular setup of that particular tissue, which is being formed in the lung. Sometimes there are scenarios where you can't biopsy the tissue because it is located at such a condition, or the patient is in a very frivolous or a bad clinical condition. So in those cases also, liquid biopsy can identify the targets which you can use for better management and correct management of that patient. Also, it helps you to monitor the disease. So you can't do a biopsy again and again. So when a patient has had a relapse or has progressed on the current treatment, so then in that case, we can't go and puncture again, because mostly the patients are also not very interested in doing that. But a single blood draw can essentially give you the complete tumor landscape at that point of period. And the last scenario is to predict early relapse. So there are also tools now available where you look at the ctDNA level. That is the tumor fraction in the blood. So when you give a therapy, you look at the ctDNA level, and then again after a 3 months or a 6 months period time, you can keep monitoring the ctDNA levels. And that is calculating the tumor fraction, which is done by mostly low-pass whole genome sequencing and also a combination of methylation profiling of that free-flowing DNA. So those are the nuances where ctDNA and tissue biopsy and liquid biopsy vary.
Just to add to that and just to clarify, so in the present scenario, as of today, liquid biopsy is used for diagnosis. So that is as per the guidelines. You can use it. The use for as a monitoring tool, this is going to come. This is on the verge of coming, but still it's not there in the guidelines. So that is the thing. And coming to screening. Screening, unfortunately, is not there. It is only low-dose CT which is there. There are a lot of articles which are there and lot of research work which is going on. In fact, I think some of you must have heard about the Gallery liquid biopsy test or the Delphi method. So they have shown lot of promise. So what they are actually doing is that they are taking blood and they are looking at certain patterns. So your normal normal person's blood has a certain fragmented DNA pattern, which using a AI, they have categorized the patterns of lung cancer, colon cancer, breast cancer, and try to identify those patterns. And based on that patterns, the early results show that for lung cancer, since this is a lung cancer conference, that for stage 4, there is 78 to 80% detection, but for stage 1, there is around 20-25% detection rate. But yes, these techniques are still not there, but we need lot more data on them, and even the methylation techniques which Dr. Charu has been referring to, they are still in the realms of research, and they are not there. So I would like to, yeah, that's for colon. For colon it is there, but for lung they are not there. Yes, but it is a very promising field and lots to come. That is one thing. And another question, Dr. Charu, I have. So everybody, I think in first 2 presenters have been referring to the genetic. So lot of thing is in your genetics. So I would like to ask you, so since when it comes to molecular is genetics, okay, genetics of the tumor, genetics of normal human. So what is the role of genetics in lung cancer?
So see, it's a broad question. So when I say role of genetics in lung cancer, frankly, in my PhD, I worked on genetic predisposition to lung cancer. In North Indians with Dr. Navneet Singh. So in that, we were looking at predisposition factors that can lead to lung cancer. So that means that's like a inherent ability of an individual that he will have a higher risk to develop lung cancer as compared to any other individual who hasn't. But those all those studies, I think they are just going on. We are having a lot of data. But right now, if we look at germline predisposition to lung cancer, there is only EGFR T790M, which if you see upfront can be a reason that you may have hereditary lung cancer. Other than that, there could be contributing other mutations which can cause lung cancer. If you have an additional exposure to, let's say, carcinogens, you are working in an industry, or you are exposed to pollutants at a level which is higher than normal level, which we now, like a gas chamber in Delhi, we all are. So, and obviously cigarette smoking is there. But genetics, this is one part of it where I'm talking about the germline predisposition. The second part of it, when the patient develops or acquires lung cancer because of the environmental exposure, there will be a lot of changes at the molecular pathway levels that happens. And that is highly heterogeneous in lung cancer. Because there is a, I believe that when we take in air, it goes to the lungs, and that's why there are a lot of mutations that can happen. And that is what happens, and that is why lung cancer is a poster child for targeted therapies, because we have a lot of you can say it's a highly heterogeneous disease. And that is also seen when we look at the reports, because when we do the biopsy from a certain location and we do a molecular profiling, we get some mutations. But when we do a liquid biopsy in a stage 4 patient, we might get some additional mutations as well, because the tumor itself, in itself, is a differentiated body. The cells around the tumor will have different mutations in different locations, which is called tumor heterogeneity. So those things also have to be kept in mind when we talk about genetics of lung cancer, and that we have clearly seen. So that is what my take on it is.
Yeah, as you rightly said, I will just like to summarize the whole thing. Role of genetics compared to ovarian or breast cancer is lesser, though it is not that is not there, but it is definitely far lesser. So maybe as per the literature, around 2 to 5% is genetics, and more so EGFR, those mutations. There are few others also, and then there are BRCAs, which usually known with the breast. So they are also could be associated with. Yeah, so there can be, but these are very rare in this thing. But then there is another thing which I would just like to refer, which is a very common sense, and till now we have not been giving very good answers to that. There are people who smoke like chimneys, but they will never get lung cancer. And there are people, and I think most of the clinicians have seen these patients. भाई हमारे ये तो non-veg भी नहीं खाते हैं, कुछ पीते भी नहीं हैं, smoke भी नहीं करते, इनको क्यों हो गया? So that is also there. And because as we say in molecular, it is your karma through your genes. So you have certain genes which are rapid metabolizers and which are poor metabolizers of cytochrome P450, but right now these are not in the diagnostic realms. Again, these are again for the research. But yes, very soon you will be having those kind of figures also coming up, because this field where we are is a very happening field, and lots of things are coming. So with that, I open the house. If there are any more questions, please. Yes.
Good evening. So very well presented by Dr. Charu, and very nice discussion also. So just wanted to have two questions. First of all, how you see the real world evidence generation will impact the current scenario of less screening of the patients? And second thing is, as ma'am you have already mentioned, the pollution and smoke are a pivotal cause of having more female cancers. But the thing is, ma'am, couple of years back, our like dadis and nannies, they used to have not having the proper gas facilities. They used to cook and spend a lot of time with this having intake of this smoke and other things, right? So that time, yeah, genetic modification, yeah, environmental pollutions, that might be attributed cause. But what is your thoughts? Like, what are the other significant factors are playing important role, and how we can prevent ourselves getting affected? So to specific questions.
Compared to, you're talking about that generation. So look, one thing is very important. Our age, longevity has increased. So that is one big thing. So that is why you're seeing so many cancers also. That is, and plus the pollutants, everything. There are so many processed foods. Everything is processed. So that is adding. Even you, me sitting here, this is light, everything. There is a lot of mutations going on in our body, but they are getting repaired. But yes, there are some mutations which don't get repaired, and then they carry on, and then they multiply from 1 to 2, 2 to 4, and so on. This goes on. It's a multifactorial thing. It is not one thing. Even if you have a genetic association, you have a gene, it is not there that you are going to have that lung cancer or this thing. It just increases your risk. There are very few genes which have almost absolute risk. Let's say, for example, 100% risk. I think FAP in colon cancer is just one gene which I can recollect. But all these genes, they just increased your risk. It is the addition of other factors, which I think it's like a healthy lifestyle. If you live, if you're thinking of what can I do, it's a healthy lifestyle. It can be beneficial from all aspects. So that is there.
My second question was on the real-world evidence. As Dr. Charu presented so many biomarkers, right? And in the era of precision medicine, it is very important to have this biomarker tested. So do you think that we are generating enough evidence for Indian scenario? And what else can be done for this space? What would be your suggestions?
What was presented was in the diagnostic. The patient is already a diagnosed case, and these are the biomarkers for which drugs, they are either prognostic, predictive, or therapeutic. Something is available, and their incidence in our particular scenario, Indian scenario, is quite different from what it is in West. Even say for example EGFR, ours may be around 30-35%, and there are countries like Vietnam where maybe it may be above 50%. So that is different from base to base to country, but for screening I think still we are not there yet, right? You want to add something?
Hi, I'm Ritesh here. So thank you for this genetic aspects of this particular disease. Basically, I would like to just understand how you decide whether the patient should go on somatic or germline. This is the first part of my question. And the related to this is that how you are considering that patient don't know about the genetic aspects of their parents or ancestors. I'm taking this as a consideration. Second part of that low pass sequencing that you explained, how you see that difference in data as compared to somatic or germline comparison to low pass? How this low pass will be better as compared to somatic and germline? This is two different questions, sorry.
Okay, so germline is like all cells of your body have it. You are born with it. You can blame your parents because you have a pair of chromosome, one coming from the father and one from the mother, and there is very few novel things there. Okay, so that is germline. Somatic is which is only in the cancer, in the tumor. So if you have something which is in the tumor, and if you're supposing born with it, your tumor will also have it. Okay, that is the basic premise, like it's to bring it to a very simple level. So that is the premise. So if you, and when we see the molecular report or we see the molecular markers, and there are certain hints in the report which tell you that, okay, this could be germline. You could be born with it because the one is the VAF, the variant allele frequency is very high. So we say, okay, you could be born with it, but it's not a diagnostic thing. You need to get a blood sample or a saliva sample to get it confirmed. So that is there. And you talked about low pass, so I could not understand. There's low pass sequencing is one thing, which is like totally.
I'm just. I would like to know, ki, ma'am, Charu told that we should also go for methyl and low pass sequencing, whole genome low pass sequencing. So the data derived from low pass whole genome sequencing or methyl is still in the development phase because we are not know how to do deal with that methyl data. What depth should we go on that? And by the way, both are the similar as well. So how the data derived from low pass and data derived from exome, whether somatic or germline, how this data will be different? How should we go?
So basically, low pass whole genome, what I was talking about is to look for structural abnormalities and patterns so basically what we are doing is we are sequencing the DNA only one time or two times, that's it, 2x. That is what is called low pass genome sequencing. So it gives you the pattern and we compare it with the normal DNA. So basically we look at the normal DNA pattern and the tumor DNA pattern. So the tumor DNA, when it is put to low pass whole genome sequencing, you will have certain regions of the genome showing variation at the there will be a loss of data, there will be a gain of data. That means there are structural abnormalities, chromosomal losses and chromosomal gains, by which we identify that this is a DNA from the tumor. So that is how we calculate the tumor fraction. So that is entirely different from what we do in exome. Basically in exomes we look at the, either we do a whole exome on blood or we do a whole exome on tissue. So basically those are more of targeted panels.
They don't look at the larger, like a structural abnormality as such. So when we do low pass whole genome, we can look at structural abnormalities and not at point mutations. The point mutations are not very nicely picked up in this because we are not going deep into it. So that is the concept.
So what actually she is referring is that, okay, tissue biopsies, you picked the tissue and you did the sequencing. Liquid biopsies, you took the liquid. But it is not always that your liquid biopsy will have the mutations from the tissue. It is quite possible if we call it, there are certain tumors, around 75% of the tumors will give you mutations in the liquid biopsy. There are 20-25% tumors which are non-shedders. You will not find mutations. So if a report is negative in liquid biopsy, how would you know this report is negative or was the person non-shedder? Okay, so to do that in liquid biopsy, what is done is we do and this is usually done for a bigger panel of liquid biopsy, not few genes. So when you have lot of genes, you do that. You do a low pass whole genome sequencing, and there you can see, okay, there is a variation compared to the normal. That means this thing at least is coming from the tumor. Okay, and if it is negative, that means it is negative. The tumor is there, but the mutation is negative. So that's a true negative. Okay, versus the indeterminate test. So that is the use in liquid biopsy for this kind of thing, whole genome sequence.
It's to calculate the tumor fraction. What is the tumor fraction in the blood from when we look at because it will also have DNA from the normal cells. So that is also there. Yeah.
So I have a question on targeted therapies cost. So wanted your comments on that. I think one of your slide you had I think lung cancer has lot many targeted therapies compared to other cancer, but the cost of these therapies are too huge for India. So one is, of course, we are asking for a very high cost test, and then the result comes you have to get, let's say, amivantamab, which costs lakhs, and the overall survivor it's promising is about just 7 months extra. So what's your comment on that? We are wasting so much of the money, but in the end, the benefit to them is very small.
Okay, one thing is cost. First, the cost. Look, most of these things, they start with US. They have a patent. Till that time, nothing comes. But what happens is we develop a generic drug. EGFR is one good example, and the cost is maybe 4,000-5,000 per for one month. Okay, which is affordable, I feel. This is what happens. So that is one scenario. But if you look at lung cancer in India, it will cover 35% of your non-small cell lung cancer, which is big. Okay, which I feel is big. It's like looking at the glass half filled or half empty. Then you talked about these drugs, which are very costly, of course, because they are not patented, no generic drug there. But then there are clinical trials. Okay, so you say, why do a costly test and when you can't afford? That's a very good question, and with a common sense. The thing is, how do you invite clinical trials to your country? You tell them you have this thing. Okay, unfortunately, if you go to US, you can see that most of the people will either be covered in insurance or in the clinical trial. But in our country, we have limited clinical trials, though we still have a lot of them. But even for those clinical trials, the patients are not enrolled. So that is the thing. And I think the patents are coming off, and India is already, I think, the pharma king. So we are already getting more and more generic drugs, and more biosimilars are coming up. So this scenario is changing. It's not going to be there. And the more we test, the more we can invite trials to our country also. So that's the...
Hello, ma'am. I am a pathologist, ma'am. My question is a little bit on a technical point. If we get a biopsy, so we process it, we get a formalin-fixed paraffin block, and we already cut a couple of sections to diagnose it as a non-small cell cancer or adenocarcinoma. So for molecular analysis, because I had a couple of patients that blocks were returned from AstraZeneca and MedGenome as well, because the tissue was very limited. And we can't subject the patient to another interventional procedure. So how, I just want to know what can be the adequate biopsy so that we can do the diagnosis on histopathological examination as well as the molecular analysis, so that we can guide the patient on spot that, okay, this is sufficient or we won't be able to do it.
Okay. So I am a pathologist and I'm a PhD. So I can understand both the fronts. So I'll tell you, as per the guidelines, they say that just do minimal markers, okay? TTF1 and P40, that's it. And after that, send it for molecular. Don't waste, because in lung, tissue is a big issue. Okay, you need to preserve tissue. So that's one thing. And then even still no tissue is left, and once you diagnosed it, you always have a backup of liquid biopsy. So that's there. But you should preserve. Then there are different practices in different hospitals. So at time the radiologist takes 2 codes. One he sends for the molecular, the other is for the histopathologist. That is one approach. There is another approach which I think we have been practicing in our hospital. We do FNAC and biopsy. Okay, so do FNAC, and FNAC, even a stained slide, is a very good resource of molecular material. So that I think most of the people don't know. So you can use stained FNAC slides also for molecular testing. So that is also can be used. So these are the tricks, little tricks. If you know, you can do the best. There is no perfect world, but you will be able to save a lot of things. No extra IHCs. No, I say maybe there has to be a good number of cells. Yeah, cellularity is there, but yeah, even just doing a biopsy versus FNAC and biopsy, so I think maybe 30% of the times we were able to use the FNAC for NGS when the tissue was not available in the biopsy. So that's there. And you have to realize that only 70-75% of your cases will be picked up by liquid biopsy. 30% will still remain. Tissue is still the gold standard. Okay.
Thank you.
Thank you. Please give a round of applause to the 2 lovely ladies on stage who have given us a lot of insight on the molecular side of the disease and how lung cancer is the poster child for molecular treatment and advanced treatment based on molecular biology. I would now request Dr. Sampurna to please come up on stage. She's from AstraZeneca, and I request her to please present our speakers with mementos. Dr. Sampurna of AstraZeneca, I request you to please come up on stage and present a memento to Dr. Maushmi Suryavanshi. And a memento to Dr. Charu Behel. Thank you. So far we've spoken a lot about screening and new advancements in molecular biology that will help in personalized treatment. So now we're going to focus on lung cancer treatment insights, and what we are trying to figure out is what insights do we get from multidisciplinary lens. So this is going to be a discussion, and I will request for the stage to be set for our speakers to come. In this session, we will explore the latest advancements in the management of non-small cell lung cancer, NSCLC, and small lung cancer, SCLC, focusing on the practical application of global guidelines in various clinical settings. Experts will discuss cutting-edge therapeutic options, including immuno-oncology therapies, trinase kinase inhibitors, and antibody drug conjugates, with particular emphasis on personalized treatment approaches for resectable, unresectable, and metastatic NSCLC. This panel will also highlight the current challenges in SCLC treatment, the DGCI-approved therapies in India, and the impact of real-world evidence on clinical decision-making. Finally, the discussion will also address future trends and innovations in lung cancer care. So I'm going to request our speakers to please join us. I request Dr. Saroj Das Majumdar, Professor and Head of Department, Radiation Oncology, Department AIMS, Bhubaneswar, to please come up on stage. He'll be moderating this session. I would request Dr. Bilal bin Asaf, Founder, Trustee, Associate Director of the Institute of Chest Surgery, Chest Oncosurgery and Lung Transplantation in Medanta, the Medicity, Gurugram, to please come up on stage. These are our speakers who are present in person, so I request them to please take a seat. Our other speakers are joining us virtually, and they will be joining us in a few minutes as soon as their connection is done. We'll be joined by Dr. Sridhar P.S., Senior Consultant, Radiation Oncology, Apollo Hospitals, Bangalore, and we'll be joined by Dr. Aditya Murli, Senior Consultant, Medical Oncology and Hemato-Oncology, Apollo Hospitals. So I request Dr. Majumdar to set the poll rolling, and we'll have our other speakers join us, and then they can be included in the discussion as well. We have Dr. Navneet Singh, Professor, Department of Pulmonary Medicine, Postgraduate Institute of Medical Education and Research, PGI-MER, who will be joining us virtually as well. So I'll hand it over to Dr. Majumdar to take this conversation forward. Would request you to please show the to load the deck for Dr. Majumdar for his initial presentation. So you can keep this in case you want to know the names of the speakers of the session. You be the moderator. We have Dr. Sridhar, Dr. Bilal is sitting here. Then we have Dr. Aditya and Dr. Murli.
Good afternoon. So we have experts on the panel and online, Dr. Sridhar PS, and may I know, please?
So my name is Dr. Bilal.
Okay. Yeah. Dr. Bilal, the surgeon.
Yes, I'm a thoracic surgeon.
So, as you know, we discussed lung cancer, the present in different stages, stage 1 to stage 4. So, it's a multimodal approach. So, Dr. Bilal, in your practice, how many patients they come to you at stage 1 or stage 2? Can you please tell what is stage 1?
Yeah, very rightly said, sir. So, any cancer is staged into, by and large, 4 stages. And stage 1 and 2 are essentially those cancers which are early in their early stages and can be treated by definitive intent. So by and large, if you look at the current staging guidelines, if there's a tumor which is less than 3 centimeters in size, typically that will correspond to stage 1 tumors. And apart from that, it should be node negative, and there should be no metastasis, of course. So these are stage 1. And stage 2 cancers, of course, will include cancers which are 2 to 5 centimeters in size. And depending upon whether they have a Hyler node or not, further staging is done. So answering your next question, I think it's a universal thing. Most of the patients of lung cancer that come to us are usually beyond the scope of any definitive treatment, and nearly about only 10 to 15% patients will come in early stage lung cancer where a definitive intent therapy can be considered.
Yeah, good afternoon, Dr. Navneet Singh. I think he is online available. So in your clinic, sir, how many patients? First, please tell to the public what are the common symptoms and how they present, and how do you know that this is advanced or very early stage? Am I audible, Dr. Navneet Singh? Please. In your clinics, how many patients do come in early stage, and what are the types of presentation for early stage and advanced stages?
Your voice is not audible.
coming. Just like in pulmonary tuberculosis, we see cough, hemoptysis, chest pain. Similarly, the cancer patient also, they present like this. Mostly in our hospital, they come through pulmonary medicine basically, and they are diagnosed. So, sir, what are the methods of diagnosing in your clinic you have? Some patients are referred from the periphery and some are from the referral centers. So what are the methods of diagnosis?
To us.
That patients present us with, and when we see that and we find a mass lesion which we suspect.
Can you hear me?
Yes, we can hear you. Hello. I think audio is disconnected from this side.
Okay, can you hear us? Hello.
This problem is going very frequently.
Sorry?
In Delhi, the congestion problem is going very frequently. The
Yeah,
chest pain, and various symptoms is going very frequently
Right.
these days.
Yeah. No, so the point is what I'm trying to tell you that there are a couple of patients who would be having a chronic cough. For example, many patients with COPD will be having a chronic cough, but there is a new onset cough which is persistent, and it's always better to consult a local physician in order to get that clear that this cough is not very sinister in nature. So the message that should go across is that you should not try to treat yourself based on the fact that you have been having cough and now it's increased or decreased, but rather you should consult an expert. And anything, a persistent cough, chronic chest pain, unintentional weight loss, or blood in sputum, these are all signs that you should go to a doctor and get yourself checked. And as Sir had pointed out, I was telling about the CECT chest and upper abdomen. And once we have done that, if there is a mass lesion, we need to have a tissue diagnosis. Everybody in the discussion today, since morning, have been talking about the importance of tissue diagnosis in lung cancer, because a lot of our cases of lung cancer are being misdiagnosed as TB. And therefore, the first step would be to get a CT scan imaging, confirm whether there is a mass lesion or not. And once there is a mass lesion and you find it suspicious, then we go for other investigations like whole body PET CT and brain MRI, depending upon what the pathology will suggest us. So the next step for the diagnosis would be
maybe nuclear medicine people will tell advantage of PET CT scan.
Yeah, so as a surgeon, I would also know. So if a patient presents to me and it's a high risk case, I would go ahead and do a PET CT straight away. Because it gives me two advantages. Number one, it will give us an idea whether this lesion that we're talking about is a malignant lesion or not, number one. And number two, it also will give us possible sites of target. So for example, if there is a patient who has a left upper lobe lung nodule, and he also has some prominent PET positive lymph nodes, then both of these need to be addressed in order to be able to define the treatment strategy. And that is why for me, if a patient comes to me and is highly suspicious of having a cancer, I would probably go for a PET CT also in the initial evaluation.
This PET scan is adequate, or you go for mediastinoscopy or nodal staging? So then, after staging is done,
so once
when you call it early stage, yes,
so for an early stage, typically let's define it as a very early stage and an early stage disease nowadays, because there is a concept of what is known as lung preservation surgery, and we try to reduce the amount of lung that we are removing from the patient. And in these cases, if a tumor is peripheral, less than 2 centimeters in size, and does not have any lymph node, then this will be typically called as a very early stage lung cancer. But typically, any patient who has stage 1 and 2 and some of stage 3A cancers, which are under the purview of surgical treatment.
So, sir, please tell me the situation in stage 3 where surgery cannot be done.
So stage 3 is a very heterogeneous group of cancers. So when we talk about stage 3, I think it's best to define it in terms of the nodal involvement. So there are people with stage 3 cancer who will have a large tumor, and by that definition a T4 tumor and an N1 tumor, which will typically be at stage 3A tumor, and do not have mediastinal nodes. So there is a group of patients who have Stage 3 because of the tumor characteristics, because of being large or being involving additional structures, but they do not have any nodal involvement. These will be classically called as stage 3A tumors, and they can still be considered for surgical intervention after appropriate neoadjuvant treatment. However, there are a group of patients who would definitely not benefit from any definitive surgical intervention, and these would be those patients who have nodes on the contralateral side, which is typically the N3 nodes, or those nodes in the mediastinum which are multiple stations or bulky nodes, and also those patients with N2 disease who may require pneumonectomy for resection. So these are not good candidates for surgical intervention.
Yeah, just to take the audience on board, this lung cancer can be small cell, can be non-small cell, and non-small cell can be adenocarcinoma, can be squamous cell carcinoma. Every type of cells are having different biology. Suppose small cell carcinoma, it will, 1 week time it will double the tumor size. Squamous cell and adeno both are called non-small cell. So pathologically it is decided. Distribution wise, maybe adenocarcinoma will be located peripherally. Non-smokers will have more adenocarcinoma. Smokers will have more of small cell as well as squamous cell carcinoma. So now when this tumor is there, it will take some time to grow locally as well as regionally. So according to that, TNM staging is done, stage 1, 2, 3 like that. As sir told, N1, N2, N3. N1 means hilar lymph node, same side of the tumor. N2 means mediastinal lymph node, ipsilateral. N3 means opposite side, and scalene lymph nodes. Actually, surgery is done only when up to N2 single stage. That is good for surgery case. Many a times surgery is done knowing early stage. It is also upstaged at the time of surgery. Like 30% of the patient may be upstaged. So now it is very important that the cure, primary cure of the cancer is surgery, if it is possible. But as the presentation we saw today, only 5% of the patient will have early stage. So the screening system and early diagnosis will help us to catch the patients only when it is operable. Operation means there is 80% cure rate.
Can you hear me? Hello?
Yeah, I can hear, but whether you can hear us. So what we know that surgery is like can be pneumonectomy, can be lobectomy, or waist resection. So how do you decide which surgery will be better? Now you know surgery is curative. We want to do that modality of treatment.
Right, sir.
And what type of surgery, what is the cure rate?
So if the patient falls into the purview of surgical treatment, as you said, early stage lung cancer, and we know that surgery is the best chance for attaining long-term cure for these patients, then we come to what is known as what is adequate surgery. That the question basically is what is adequate surgery. So if you see there is a cancer, let's say we have 2 lungs and 3 lobes on the right side and 2 lobes on the left side. And let's say we have a cancer in the left upper lobe, which is, say, 5 centimeters in size. So the surgery will be decided by the location of the tumor, the size of the tumor, and that will guide whether a lobectomy will suffice or some additional treatment can be considered. By and large, if you ask a single question in today's scenario, for tumors which are less than 2 centimeters in size, and those which are peripheral in nature, in location, and do not have any mediastinal or hilar lymph nodes, we do what is known as a sublobar resection, which is known as a segmentectomy. So wedge resections usually are to be avoided in all, because these are only done in those patients who are very low risk candidates for surgery, and therefore just a palliative resection is required. And otherwise, wedge resections usually do not have much of a role in oncology. But when we talk about segmentectomy, there are recent evidence from recent trials, the Japanese JCOG trial and the CalGB trial, which both of which suggest that for tumors less than 2 centimeters in size, peripheral location, and no nodal involvement, a segmentectomy is an adequate procedure because it gives similar advantages as much as a lobectomy. But anything beyond that, where you cannot achieve a tumor margin ratio. So when we talk about resection, we always see how much far the tumor is from our resected margin. So for example, if I've cut the lung here, then where is the tumor located from my cut end? And if this is margin tumor ratio, which means say the tumor is about 3 centimeters in size, I should be able to achieve at least 3 centimeter margin, then it will be considered as adequate surgery. And therefore, if we can achieve that by segmentectomy for less than 2 centimeters, that is the choice. But otherwise, for all other patients, lobectomy is the standard of care. Very rarely, if the tumor is involving the major vessels which are supplying to the right or the left lung or the main airways, there also we do a lot of bronchoplastic procedures and try to save the lung as much as possible, because pneumonectomy in itself is a disease and we try to avoid removal of the entire lung as much as possible. But when it is required for some diseases, we definitely do it.
Tumor with adenocarcinoma and squamous cell carcinoma.
Right, sir.
The surgery is different or?
No, sir. In terms of surgical treatment, it will be the same. The standard treatment for these patients, most of these patients, would be a lobectomy and a systematic mediastinal lymph node dissection.
Okay.
Yeah.
So whether it is stage 1 and 2, surgery is gold standard.
Yes.
Stage 3, you have to select.
So
who are the ideal cases for surgery?
So stage 3 is a very heterogeneous group. Now here, I would like to just point out that a surgeon's involvement is very, very important, and these cases are to be dealt in a multidisciplinary setting. You cannot, alone as a surgeon, decide whether surgery would be the best parameter for these patients. And therefore, what we do for these group of patients is that we take a multidisciplinary tumor board where there is a thoracic surgeon, a radiation oncologist, a medical oncologist, a respiratory physician, a radiologist, and a pathologist. And we discuss the patients in total and then take a call what is the best treatment parameter. So by and large, if I want to give a very clear instruction, is if there is a patient who has a large tumor that can be downsized by neoadjuvant chemotherapy, surgery will still be important in stage 3 cases. But those patients who have multi-station involvement, so there are multiple mediastinal nodal involvement, or there is a tumor N2 involvement which will require pneumonectomy. These are the patients that we would scare slightly away from surgery, because if you look at the data, the advantage with surgery versus giving the chemoradiotherapy would not be much different, and the surgical mortality rate and the morbidity rate would be higher for this group of patients, and therefore we would recommend surgery in stage 3A cancers only, where there is a single station, non-bulky N2 disease, which can be handled by a lobectomy.
So can I bring in Dr. Aditya if he is audible? Dr. Aditya, stage 1 and stage 2, after surgery is done, anything you want to add? I think
I think we do not have a connect.
So, as we know, surgery will cause 90% control, local control. So, there are some cases where you need to add also after surgery. So, who are those cases? If you can take this question.
Yes, sir. Adjuvant chemotherapy and nowadays adjuvant targeted therapy and immunotherapy also are coming into picture. So, we've seen that lung cancer cannot be classified as a localized disease based on certain parameters. And we want to prevent recurrence, because sooner or later, if you follow these patients long enough, many of these patients will recur with lung cancer at some point of time. And therefore, what do we have to try and reduce those recurrences is we look at the pathology of the tumor. So again, the stage of the disease which comes after the final histopathological evaluation is what we look at to decide for adjuvant chemotherapy. So if there is a patient which has a large tumor more than 5 centimeters in size, or if there is a very poorly differentiated tumor, or there is evidence of spread through airway, or the margin is closed, or there is hilar lymph node involvement, all these patients traditionally would require chemotherapy, and definitely would require. But nowadays, if you look at the ADAURA trial and the targeted therapy things, so these targeted driver mutations are available, and there is strong evidence towards the use of adjuvant targeted therapy in patients of stage 1B onwards.
As sir told, in colon cancer, suppose T3, N0, stage 2, even after surgery, chemotherapy very limited role. But in lung cancer, even after stage 1, the 5-year survival is up to 70%. Always there is need of doing something extra so that you will reach to that 90% 5-year survival. So many studies are going on. Adura trial, as sir told, is one of them, which means still previously only stage 4 cases will go for EGFR ALK molecular profiling. But nowadays, even if stage 1 and 2, you will go for molecular profiling. If there is EGFR mutation, then only this osimertinib, Tagrisso, osimertinib will work. And this is EGFR, it's a tablet form, so there is progression-free survival is already there. So there is adjuvant. This is a new thing. Prior to that, there was adjuvant chemotherapy like in Anita trial. So this adjuvant chemotherapy means when there is node positive, margin positive, or high risk features like LVI, PNI, then only will add chemotherapy. So once early stage tumors are treated with surgery, followed by plus minus targeted or immunotherapy, like in IM power study one is there. You can add on that. That is not standard of care yet in our country. So once this is done early stage, there are some cases where actually technically surgery is possible, but medically patient is not fit for surgery. In that scenario, maybe this is a question for our colleague from radiation oncology, Dr. Sridhar. If still you are there, you can take on, otherwise I'll tell.
Can you hear me, sir?
Yeah, I can hear you. Please go ahead.
Yeah. So thank you for adding me, and sorry there was a connection problem. I didn't hear the previous questions properly. If I understood correctly, we are discussing about the early stage cancers, lung cancer, where we think that for ABC reasons, if it is difficult to treat or the disease has come back, definitely there is another alternative, what we call it as SBRT by the stereotactic body radiotherapy by CyberKnife or other areas. It definitely makes a lot of difference vis-a-vis with the surgery. The results are all as par with the surgery nowadays, where there is no need of considering for a surgical in these cases. Definitely there is a role, and addition to that, as you rightly said that I was talking about adjuvant treatment in terms of the role of immunotherapy and the targeted agents along with the SBRT is upcoming now, and definitely it can be used. It's a short treatment, and the local control is in the range of more than 90 to 95%. We can definitely take care of the lymph nodes also, if involved lymph nodes, if it is required. So even in a metastatic setup also, what we are looking at is an oligometastatic.
Just for the audience, for our audience, what is this radiation? What is the mechanism? Surgery we understand, but for radiation, how it works?
I'm not able to hear you properly.
My question is that historically there was routine radiation was there, but it was not effective. So how this new modality of SBRT is effective like surgery, as you told? So how this radiation works and mechanism of action?
Yeah. So conventionally the radiation was given as a small fractionation, but when we modified the fraction to the higher dose per fraction, so we have seen that the radiobiologically it is different, and the effectivity, the local control is becomes more, and the tumor control is better. So the radiobiological aspects of large fractionation, and in terms of biological aspects, we call it as alpha by beta ratios, and where we see that the effectivity of short fractionations will have a long-term control.
Okay. So how many days you give treatment?
So if you go back and check it out, what is stereotactic body radiotherapy is, we do the PET scan and the MRI if it is required, and mark only the tumor. The conventional fractionation is around 6 to 7 weeks, up to 6 weeks of radiation, 5 days a week to 5 to 6 weeks. Now it is concised only to the 5 days of radiation. So because of that, the higher dose per fractions, which is equivalent dose, the radiobiologically is effective. So it's only for 5 days of treatment. So it's a short course and it's only the 5 days.
And what are the sequelae after radiation? Any side effects?
Doing the SBRT by CyberKnife for last 18 years and done more than 800 patients for lung cancers. And if you say metastasis, maybe more than 1,500. So the treatment-related side effects are practically nil. Where why it is the treatment-related side effects are less? We don't give extra margin to the normal lung. The most of the treatment-related side effects are because of the lung radiation, which is not involved. So the pneumonitis because of radiation, what we call it as radiation pneumonitis, it becomes very minimal and treatment-related. But the local, the tumor gets the full dose. Because of that, there is the effective local control, and the short-term and the long-term side effects of the lung irradiation is practically it is not there. Morbidity because of the radiation is not there. This has made a really revolution in terms of lung cancer treatment.
Yes, the radiation is just like unseen knife. Tumor problem is that in the lung it moves with respiration. So giving radiation targeting the tumor is a problem. So once radiation will pass through normal lungs, lung is very sensitive to radiation. Radiation is given 2 gray per day. If our whole body will get around 5 gray at a time, maybe we'll die. So a small portion of the body, you can give high dose of radiation. Smaller tumor, very high dose you can give. That is called radiation ablation. So total body irradiation, very little dose we can tolerate. So how this radiation will work? This radiation like it's mega voltage, gamma rays or X-rays, they will pass through the DNA. Directly it will cut the DNA. It is called lethal direct action, or it can be sublethal. One strand of DNA will be cut, subsequently another one, like that. Otherwise, indirect method of radiation called free radicals, hydrogen ion mediated interactions. So radiation can damage the DNA, can control then when this cancer cell will divide again, it will die. Like you get a bullet, then you walk sometimes, then you die. Radiation effect is like that. Unlike in surgery, this radiation takes time, and radiation also given in fractionated manner. You'll see that somebody is going for radiation for 30 days, 20 days, like that. But this new method of radiation is given very high dose to a small area, so that there are one is killing as a DNA killing and oxygen mediated killing. Another one is called apoptosis, like programmed death of the cells. And also immunogenicity. Radiation can induce immunity, can suppress immunity also. All these factors are taken into account to control the tumor. This tumor control it is 90% compared to surgery, but the recommendation is first choice surgery. Why? Because whatever you do, there is always a risk of radiation going to another healthy lungs. There is heart, there is esophagus. All these structures will get some dose of radiation. Like this lung tissue will be destroyed in 20 gray if given in conventional radiation. Means when we give 70 gray, by 20 gray lung will be damaged. Now we have this method of delivering radiation and calculating integral dose to the remaining healthy lungs. This is the revolution came in last 15 years. IMRT, VMAT, volumetric arc therapy, image guided radiation. With all these newer technique, we can know which organ is getting how much dose, whether it is safe or not. That is why this delivery system has come. We can protect and we can give that. That is why this radiation role in early stage is also there. But recommendation is that only in medically inoperable case, those who are inoperable, they will be going for radiation surgery, means radiotherapy. Now, if Dr. Navneet is available, Am I audible, Dr. Navneet?
Was a glitch. Oops.
Sir, in your clinic, in early stage, what percentage of early stages are coming?
So as per our last analysis, stage 1 and 2 is less than 5%. Stage 3A is around 12 to 13%. 30 to 35% is locally advanced stage 3 non-metastatic, and approximately 50% is metastatic disease.
So after early stage surgery is done, what are the adjuvant therapy you recommend, sir? We want to develop a consensus. What is your thought on that?
Which are followed after diagnosis is very simple. If you have a suspicion of early stage disease on the initial imaging, which usually, if not always, a contrast enhanced CT scan of the thorax and upper abdomen, the next step is to rule out metastatic disease, and that would include doing a PET CT and an MRI brain, unless there is contraindications. Once you have ruled out metastatic disease and the stage is truly confirmed to be that which is potentially resectable, there is usually a role of sampling the mediastinal nodes to assess whether they are involved or not. And mere presence of enlarged or FTG-avid lymph nodes on imaging may not be accurate enough to determine whether they are truly involved by the tumor or not.
A small question, what is the role of MDT in your view? Whether all cases you discuss in tumor board or only for metastatic cases? I think we have lost the connection. Yeah, please go ahead.
Yeah. So stage 3 is the most heterogeneous in terms of both its implications for treatment as well as prognosis, is something which should always be discussed in a multidisciplinary tumor. Preferably all cases should be discussed. However, the very extremes of stages are usually much easier to manage. Having said that, decisions about certain stages, especially early stage, should never be taken in the absence of an opinion from a surgeon. For example, if something is stage 2 or stage 3A, the decision to not do surgery should not be done unless the surgeon himself or herself says it is not doable. So that is a very important thing which we need to keep in mind. Obviously, multidisciplinary opinions and judgment is what is paramount for almost all stages.
Since medical oncologist is disconnected, I can take this question from you also. Like there are inoperable stages. We discussed that stage 1, 2, 3A and single station N2 surgery is done. So when you tell it is inoperable, then how to go about it? So any role of surgery in 3B, 3C?
No, sir. Actually, if you look at the current guidelines,
if suppose neoadjuvant is given.
So there is a new gray area that is coming up after the advent of neoadjuvant chemoimmunotherapy, and many of these patients do respond dramatically after neoadjuvant chemoimmunotherapy. In this group of patients, if the only disease left around is localized to the lung, and if there is a good period of observing and there is no progression of the disease, then this group of patients probably will benefit from surgery.
Sometimes after neoadjuvant, we see primary has responded well.
Yes.
Nodal disease is not responded.
Yeah.
So what we'll do in that?
So the recommendation after neoadjuvant chemotherapy is to reassess the lymph nodes by invasive mediastinal staging. So if an EBUS was done earlier and it was a positive node, you should do a repeat EBUS or a mediastinoscopy to prove that the node is negative. However, in view of persistent disease, the results of surgery will not be good, and probably these patients will do as much better with CTRT. So definitive chemoradiotherapy would be considered better choice for them.
Yes. So Dr. Sridhar, stage 3 inoperable. What is the standard of care? Dr. Sridhar.
Inoperable, we will definitely consider for recurrent CTRT is one of the things we're likely to consider, and with a single agent or a double agent chemotherapy. And PET-CT is, as I rightly said, that PET-CT scan and the MRI brain is one of the mandatory tests. We want to get it done, and whenever there is a possibility after MDT, the CTRT followed by a reassessment for surgery if it is feasible. Otherwise, concurrent CTRT, whether radical intent, is the one what we are considering.
In this type of radiation, what is the fractionation and dose?
When right now I can say that modern radiotherapy techniques, the minimum should be the IMRT, IGRT is the one what we are looking. If you have a gating system, so as I rightly said, as previously said, that they do not required to irradiate the extra lung, track the tumor absolutely correctly, and reduce the margins and treat the tumor effectively. In subset of patients, if they are elderly and they cannot wait for 6 weeks, even in these cases, there is the role of SBRT is emerging, and so that systemic treatment takes a major role in these cases rather than the local treatment alone. So the combination of CTRT with the image guided and taking care of motion management is the one what I'll prefer. 66 minimum dose should be around 60 to 66 gray, and only to the tumor. That is what the minimum dose what we'll do it. So as personally, I go up to 70 gray, depending on the patient condition. And if it is an SBRT, it's like 35 to 40 gray, depending on the central or peripheral dose, peripheral structures.
Yeah. Dr. Aditya, I can see you. Can you hear me, Dr. Aditya? Hello.
Yeah, this is Navneet. Can I interrupt?
Yeah, please.
So I am both a pulmonologist and a thoracic medical oncologist. And coming back to the question of what to do in stage 3B and 3C, there are few dictums of what should qualify as surgical candidates. As correctly said, with the advent of very highly effective neoadjuvant therapies, which is basically a combination of neoadjuvant chemoimmunotherapy for patients who do not have a targetable oncogenic driver alteration. That distinction between resectability and unresectability is often blurred. However, certain rules still apply. In absence of intra and extrathoracic metastasis, the primary should be resectable. There should be no contralateral lymph node disease, and the ipsilateral lymph node disease should not be bulky and multistation. However, so if you have something where you do not have metastatic disease, but you have a suspicion of contralateral lymph nodal disease, which is basically an N3 disease, that has to be decided upfront because there is no role of surgical resection in N3 disease. The rest, which is the primary being resectable and the presence of ipsilateral lymph nodal disease, that is something which highly effective neoadjuvant therapies can take care, and perhaps there's a school of thought that you might make unresectable resectable. There are proponents to that theory and there are proponents against that theory as well.
So once chemoradiation is done, this is inoperable stage 3 cases, but non-metastatic. So this is standard of care. Some they practice giving chemotherapy after that as maintenance, or some they give durvalumab. So what is the thought? What is your take on that?
So as I said, if you have done neoadjuvant chemo or chemoimmuno, and after the initial assessment it was felt that this is not resectable, you can go ahead and do definitive chemoradiation for unresectable stage 3 disease. Subsequently, the important thing which has to decide the further consolidation therapy is going to be both the presence or absence of EGFR and ALK and PD-L1 expression. So if it is EGFR mutation positive, there is absolutely no role of giving durvalumab because these patients are not going to benefit from that. In fact, the preferred drug is going to be an EGFR tyrosine kinase inhibitor, and the data for that is from osimertinib. PD-L1 expressor also will tend to benefit the consolidation durvalumab. I am not so certain whether you should give durvalumab to have PD-L1 expression of 0, although the approval is irrespective of PD-L1 expression. And finally, if patients are not candidates for durvalumab consolidation and there is no targetable oncogenic EGFR or ALK, you could consider consolidation or perhaps called maintenance pemetrexed for non-squamous NSCLC.
So when that durvalumab is given, only on progression or when to start or when there is stable disease, how do you decide? Suppose suitable, there is no driver mutation, CTRT is finished, then when to start and what are the investigations I have to do?
By definition, this consolidation durvalumab is when you do not have disease progression with the initial chemoradiation. So, and that could mean either a partial response, rarely a complete response, or stable disease. These are the candidates, and obviously patients should be fit enough, should have recovered from any toxicities experienced during the chemoradiation. And these are the candidates for whom you would consider durvalumab consolidation. The tests which one would do, or what one would do for immune checkpoint inhibitor therapy in general, and that would be doing a CBC, LFT, RFT. Specifically for immune checkpoint inhibitors, one would do thyroid function tests at baseline, as well as a urine analysis, and monitor these during the course of therapy. Because these patients have also received radiation early on, one would need to be very careful, monitor for signs of development pneumonitis.
Yes. So just to summarize, when operable, go for surgery. Inoperable, stage 3 means locally advanced non-small cell lung cancer, you have to go for chemoradiation. Chemoradiation is 6 weeks treatment. So chemotherapy and radiotherapy is given concurrently. Other like sequential therapy, there is no much benefit. Concurrent therapy is superior. So concurrently it is given. Then from 4 to 6 weeks time, when patient is stable, no evidence of progression, you can add durvalumab if it is feasible, because it's costly medicines. So even if you do everything, then the 5-year survival rate is like 50%. So these are all stage 1, 2, 3 cases. The next stage is called stage 4, which is metastatic. Once there is metastatic, it can be opposite lungs, it can be in the bone, liver, brain, everywhere. So as per the symptoms, we give palliative chemotherapy, palliative radiotherapy, and also immunotherapy. So sir, just Dr. Navneet sir, you tell it's a stage 4 disease. What is the experience? What is the median survival? And what is the therapy shift now? What is the new things you experience in the clinic?
I would just like to say that not all patients are candidates for concurrent chemoradiation, and therefore for such patients, if you have a lot of comorbidities, poor performance status, you could do sequential chemoradiation as well, because concurrent requires a certain degree of fitness which all patients may not have. Now coming to metastatic disease, the primary determinant is the histology and the molecular profile. So for adenos and non-squamous, non-small cell lung histologies, the most important thing is to test for oncogenic driver alterations. In India and South Asia, the prevalence of EGFR mutations is in the tune of 30%, and of ALK rearrangements is around 10%. And therefore, testing for them even by standalone tests, which would be a real-time PCR for EGFR mutations and a D5F3 immunochemistry for ALK, is a reasonable option if you do not have the resources to do an upfront NGS.
Just
if you have the
quickly, I will take a question from, suppose solitary brain metastasis and EGFR mutation is positive. So what will do? You will wait or will go for SRS or whole brain RT? Dr. Sridhar?
So, I agree a lot of points of Dr. Navneet is telling about that. So there is a unique scenarios where the role of SBRT is emerged, and we are definitely looking for still a definitive option. It may not be curative, it may not be palliative, where we call it as a oligometastatic disease. The role of SBRT is definitely there. In the situation specific to ALK, where there is a driver mutation with a single metastasis of brain, right now actually we would like to explore the option of the medications and observe if the patient is asymptomatic and the metastatic disease is not causing a problem. We would like to wait for at least 3 months and the serial MRIs, and only when there is the symptoms or if there is a progression, we can consider for the SBRT to only to the tumor. Those are the olden days where we are talking about whole brain radiation for a single metastatic disease. So we definitely condemn that. And if at all, if it is a limited number of metastases, we can go and treat only the metastatic disease in the brain metastasis and no need of whole brain. And regarding the driver mutation part, yes, and the immunotherapy part, I would like to explore the options of systemic treatment and see the responses. Then only I would like to go and do the SBRT or SRS to these lesions.
So thank you. We'll wind up. We'll take final remark. So Dr. Belal, please.
So for oligometastatic disease, again, if I'm sure that I'm able to take out the cancer in totality and there is no nodal involvement and there is a solitary brain mets, I would request my neurosurgery guys to review it, consider resection of both the lesions sequentially. So I would ask my neurosurgery team to resect the brain lesion and then subsequently, if everything has gone well and the patient is still in the purview of the surgery, we'll go ahead and do the surgical resection as well. So this is a group of patients of oligometastatic disease where you can still consider surgery as a treatment option, and particularly if you find that there are driver mutations present, that also adds to the fact that you can actually give good results with a combined treatment.
Yes. So even if stage 4, quality of life is very important. So we see that. So we give radiation, we try to prolong the life and quality of life. Thank you very much. Thank you all. Now hand over to the organizer. Thank you.
Thank you. Thank you very much.
Thank you.
Please give a round of applause to our speakers. We are grateful to them for participating in this discussion and giving us their points of view. Now I would request Dr. Sampurna of AstraZeneca to please come up on stage and present our 2 speakers who are present here. They are present physically, so we are giving them a memento to thank them for their presence here and for sharing their insights with the audience. This is of course very new, some of the things that we've spoken about, and of course some of these protocols have been there for some time, and hence a review on what are the ways, what are the protocols that work best, what sequence to adopt them, a recap that definitely helps. So I request Dr. Sampurna to please present mementos to our speakers. And a memento for Dr. Bilal bin Asif. Thank you. Now, through the day, we have spoken about the challenges we face for early detection of lung cancer. We are now going to be getting into a panel discussion. For that, we will set up the stage. And here again, we will have a few speakers joining us in person, and some of our speakers will be joining us virtually. And hopefully by now, all the setup is done and the technology is being tested so that they can join us in Qure.ai. In this panel discussion, we'll be talking about tackling gaps in lung cancer care and transforming lung cancer care in India. So in India, lung cancer is frequently misdiagnosed as tuberculosis, leading to late presentation of the disease due to overlapping symptoms and high prevalence of TB in our country, often causing patients to receive treatment for TB instead of lung cancer, delaying the diagnosis and treatment significantly. And we'll also discuss the need for India-specific guidelines, challenges in government sector management, and regional disparities in access to care. We'll talk about the role of patient advocacy groups in patient education and solution to improve equitable healthcare access. So these are some of the issues that we will be talking about in this session. We will try to come out with some actionable strategies to improve early detection of lung cancer. Please put your hands together and welcome on stage our speakers in this session. Please welcome Vandana Mahajan, Lead Counsel, Lung Connect. We also have Dr. Navneet Singh, Professor, Department of Pulmonary Medicine, Postgraduate Institute of Medical Education and Research, PGIMAR, who is with us virtually. Please welcome Mr. Vivek Tomar, PhD, M.Pharm, Certification in NGO Organization Management and co-founder, Rise to Survive Cancer. So please give a round of applause and welcome Mr. Vivek Tomar on stage. Please welcome Dr. Urvashi Prasad, former director at Niti Aayog. We'll once again call back Dr. Saroj Das Majumdar, Professor and HOD, Radiation Oncology Department, AIIMS, Bhubaneswar, and Dr. Bilal bin Asif, Founder Trustee, Associate Director of the Institute of Chest Surgery, Chest Oncosurgery and Lung Transplantation at Medanta, the Medicity, Gurugram, Haryana. We have with us Dr. Sridhar P.S., Radiation Oncologist.
Yeah, I'm there. Hello.
Right, so he's joining us virtually. And we have Dr. Subodh Kumar, Professor AIIMS, Deoghar, also joining us now. On stage, please give a round of applause to all our speakers. And please welcome our moderator for this session, Dr. Anushka Amlani. So I'm going to hand it over to Anushka to steer this discussion. Please give her a round of applause and welcome her on stage.
Good evening, everyone. Respected dignitaries and everyone present in the audience today. It's been a long day. On behalf of the Integrated Health and Wellbeing Council, it is an honor to share the stage with esteemed specialists in oncology, policymakers, and patient advocacy group leaders. As we move towards the final session of a very important conference, the insightful discussions and presentations have created a valuable impact. And hopefully, by the end of this session, from challenges to solutions, we will successfully highlight suggestions and importance of India-specific guidelines for lung cancer treatment. I would like to thank our event partners, AstraZeneca, Qure.ai, MedGenome, SCT Patom Super Speciality Hospital, Lung Connect, and Lung Care Foundation for their immense support to organize and make this event possible. We're already running quite late for this particular session, and I apologize for all the delay. But moving ahead, my first question is to Ms. Vandana. Ma'am, can you please elaborate the role of patient advocacy groups in shaping the policies and addressing the specific needs, and also the kind of work Lung Connect has been doing?
Thank you, Anushka, and thank you, IHW, for getting advocacy on the stage. I think until unless we recognize that advocacy plays an equal role in oncology, we cannot empower our patients. So like you said, first let me just tell you about Lung Connect India Foundation. Just correcting you, it's not Lung Connect, we are Lung Connect India Foundation. We are one of its kind patient support and patient advocacy group in all of India, rather Southeast Asia. I'm bragging, we were recently featured in the Lancet as well. What do? We get patients, lung cancer patients from pan-India together, try and address their concerns. We get subject matter experts to talk about things relevant to lung cancer. We do Q&A, and we share their stories, we empower them. We've done about 127 support group meetings till date without a break. We have a lot of advocacy work has gone in, so I'm just going to quickly run you guys through this. As you all know, late Shri Ravi Prakash Jharkhandi ji was a very important member of Lung Connect. Through advocacy, cancer has been made a notifiable disease in the state of Jharkhand. And we are pushing the government of India through, we've written to the policymakers to get it notifiable. I think only then, once we have the stats, can things improve. About 800 of our patients and caregivers have written to the government of India to include the funding for diagnostics, TKIs, and molecular panel testing in the Ayushman Bharat Yojana. There is a huge, huge unmet need which needs to be fulfilled. We are also pushing for equality. You know, there is a CGHS, there is an ECHS, then why are the others being left out? Why? That is another thing that we are doing. We are pushing for more clinical trials. We talk to our patients about the need for clinical trials. We educate them about clinical trials. Yes, these are baby steps, but we shall get there. We are just an year old. We're just an year old, and in a year we've done a lot. So that is what we do, and we've recently collaborated with Aspire, which is based in Singapore, and we've contributed towards policy making, towards changing the landscape of lung cancer in Southeast Asia. So that is about the work we do. Center of focus is the patient and the caregiver. So the uniqueness of Lung Connect India Foundation is it is being run by patients and caregivers. So there is no other institution involved, there are no doctors involved, it is just a cohort of 5-6 people. I'm very passionate about it, and I'm not a lung cancer survivor, but yes, I'm a cancer survivor, and yes, there are 5-6 of us. We want to stand up and be the voice for the others.
Thank you so much, ma'am. While we are definitely aware of the kind of work your organization has been doing, it's always great to listen from the ones who are so passionately, involved in the process. So thank you for sharing your story with us. We're deeply inspired. Moving on, I'll quickly ask my next question to Dr. Bilal, as I know he has a commitment and will be leaving shortly.
Yes, ma'am.
So it's been interesting to hear your expert views as a clinician in the sessions before, but it is even more inspiring when you see a clinician doing the kind of work in patient advocacy and being involved with the organization like Lung Care Foundation. So as a clinician and an advocate, what challenges do you see in the Indian healthcare system? And looking at the West, what kind of recommendations do you have that we should adopt and we can adopt at the earliest?
I think as a surgeon, me and my founder trustee, Dr. Arvind Kumar, we were faced with this problem when we used to see a lot of patients related to lung diseases and particularly lung cancer coming to us at a very late stage. And that is how the entire idea that people need to be made aware about the dreaded disease and how deadly it is. And more important was the fact that people generally have this false sense of immunity. So you see so many smokers in the country, you see so many people, there is a very grotesque image on this pack of cigarettes, but still people smoke. And you know why that is because people have this false sense of immunity that theek hai lung cancer hota hoga but mujhe nahi hoga. And I think these kind of advocacy groups and awareness groups are very, very important to make people aware and get us to get and detect more and more cases of lung cancer at an earlier stage rather than the stage that we see. And it is very difficult to, as a doctor and as a surgeon, to see patients who could have been treated if they had been diagnosed early, but unfortunately coming to you at a late stage. So I think the single biggest challenge for us as healthcare professionals dealing with lung cancer is towards the early diagnosis, the lack of awareness. And I think we must join hands with wherever possible and increase the efforts that are needed to raise awareness about the disease and also improve access to diagnostic facility. Now, not only that, when we talk about lung cancer, some unfortunate patients will come to doctor in the correct time, but then the GPs would consider it as tuberculosis, as was discussed in the morning. So again, training of individuals to be able to identify the disease at an earlier stage is also a very, very important part of that mission to try and detect lung cancer at an early stage so that we can treat them adequately. I think for me, this is a very important. And the other important aspect with which we started the Lung Care Foundation was the effect of air pollution. And because the prevalence of the risk factors that are causing the increased incidence of lung cancer, and we're going to see an epidemic of cases in the coming years. And that's because we are exposed to smoking as it is. A good percentage of our population is smoking. Those of us who live in Delhi are even, so we cannot call ourselves non-smokers. We are already smokers by virtue of the pollution that we face. There is nothing called, when you go to the periphery, these mining industries, the construction industries, there's no personal protective equipment for these because nobody cares about these things in our country except for a very few very registered companies. Otherwise, majority of the people who are working in these occupations are exposed to all sorts of carcinogens. And I think that was the reason for us to initiate the Lung Care Foundation project. And I think these are the challenges that we need to address by awareness.
Thank you so much, sir, for your valuable insights and your time today. Moving ahead, my next question is to Dr. Navneet, if you're still connected to him. Yes, I totally understand.
Sure. Thank you so much. Yeah, I am online. I am online, yes.
So building on the lines of what Dr. Bilal just discussed with us, understanding the rise of lung cancer prevalence in India, what are some primary factors that arise, particularly because of tobacco usage and the air pollution? There's a concerning trend as well in the non-smokers. So how can we enact in terms of prevention and deal with this situation?
So tobacco smoking has historically been the most important risk factor for decades. And there are ongoing efforts both at the national and international level to reduce the prevalence of active tobacco smoking. And I think there was a very recent paper in which probably amongst Indian males, it has come down slightly. The thing is, tobacco smoking, which is active, is very easy to quantify because it moves with the individual wherever that individual goes. Whether it is at home, workplace, one city, another city, the exposure is more or less linked to him. It moves with that person, him or her. On the other hand, for all of the other risk factors, the quantification is much more difficult. And whether that is what is called as passive smoking or exposure to environmental tobacco smoke or air pollution or occupational carcinogens or pollutants, that quantification is not very easy because it is going to depend upon the ambient air, the amount of ventilation, how much time that individual is there in that particular environment, and so and forth. There is no denying the fact that there are occupational exposures which are responsible for occurrence of lung cancer in a certain percentage of the population, and the fact that air pollution is a very important cause for development of lung cancer amongst never smokers. And this trend of seeing younger patients who have never smoked with lung adenocarcinoma and disseminated disease has been noticed all across the country and perhaps even in other countries. Unfortunately, there is no quick fix for that. This is not really something like genetic testing, which you can do. It's not like a BRCA testing, which you can do for ovarian or other cancers. There is no specific thing. All of the focus has to come on helping people who are actively smoking quit smoking, and to minimize exposure to environmental pollutants. And there is a concerted effort which is required to improve air quality all across. And I think patient advocates, some of whom are sitting on the dais, they have the greatest role to play. I know Ms. Vandana, I know Vivek, and they have been doing what is required to be done from the aspect of patients and their caregivers to enhance awareness as well as induce policy changes to affect all of this.
Thank you so much, sir. My next question is to Dr. Urvashi. Ma'am, in your career, at NITI, what were some of the regulatory challenges that you think need to be resolved at the earliest and that can improve adoption of innovations? We have, like ma'am mentioned, we have a CGHS, we have other schemes and there's still a need of equality where health is, treatment is accessible to all. So how can we have that adoption in yojanas like PMJ and Ayushman Bharat?
Okay, so you're talking more policy, right?
Yes.
Not regulation. I think strictly would be a different thing. So policy level, I think there's a lot of things that need to obviously happen. I think starting right from the making it a notifiable disease, I completely agree with Vandana ji. I've been pushing for that as well, that if you don't even measure something, you can never develop a meaningful solution for that. So we are hugely underestimating the burden of cancer in India. There's no doubt about that. The second is, I think, linked to the, the data part, is we need a lot of concrete research and evidence. Anecdotally, if you will speak to pretty much any doctor, they will highlight issues, of air pollution, and especially with cases going up in non-smokers and, younger people. But recently, when there was a parliament question on this, there was a minister from the government who submitted a reply saying that, well, we have no evidence to say that air pollution is responsible, because see, cancer is a very multifactorial disease. So it's difficult. It is difficult. But I think even, if the doctors can come together and put these things out much more strongly, what they are seeing, even trends, patterns that they are noticing. I understand, I'm trained in science, so I know that it's difficult to sometimes establish causality, especially with cancer, where you always have typically more than one factor that causes the disease. So I understand it's difficult, but we need better data evidence to be put out, because otherwise it's a very easy answer for the policymakers to say, listen, we have no evidence, and so why should we care about it, right? So I think that's another point. Coming to more, I'll come to the insurance part, but I agree that with cancer, we still have majority of people coming in at late stages. And so we need more better mass screening efforts, early detection efforts. I think with lung cancer, we don't have any systematic screening because obviously it's been more difficult to do, and you can't be doing CTs or even X-rays for everybody. So yes, we need better technologies to come in there so that we can screen large numbers of people, because now the definition of at risk is changing. it's not just a smoker, right? Because, you know, like we're saying, we're pretty much all smokers right now, just living in the city. So now we need that kind of screening to come in, even for non-smokers, even for people who might not have a family history, known family history, etc. So I think screening, early detection is the other part. And of course, the government has set up the health and wellness centers, but the screening there has not really been fully operationalized. And it's not just about screening. You need to make sure there's a clear referral pathway as well after that. So I think that needs to be done. And on the insurance side, I think a lot of the treatments still being supported in the public insurance are the older therapies, the older chemotherapies, etc. Cancer treatments have advanced, you know, in the rest of the world also at a very rapid pace. Now you have these oral targeted therapies, various other immunotherapies, etc. So we need to make sure that, you know, people get access to that, because you cannot, I think it's very unfair when there is an effective targeted therapy out there and a patient is still receiving a very, very old generation chemotherapy just because they are poor. So it is difficult, but we need to find solutions for that. And also, I think I would just say finally that cancer care has to be holistic, which right now is not true for many patients. And what I mean by that is that it's not just about giving chemotherapy or radiation or surgery or whatever to somebody and just monitoring them. You have to look at their nutrition, you have to look at their mental well-being, their emotional, you know, psychological well-being, because all of this really affects the quality of life. And also palliative care, something we were just discussing about outside, has to be there from the start. It's not just end-of-life care, but it has to be something provided to people right from the start to manage their symptoms as well as the side effects of treatment better. So I think cancer care, we need a comprehensive separate program, because you were talking about government and policies. I don't think the piecemeal policies here and there will, you know, cut it for cancer. It needs a separate, dedicated, holistic effort. And I think that is something that we've been advocating for, and hopefully we'll see some progress on that front.
Thank you so much, ma'am, for your insights and also for the context that you've set, that we can't make something accessible until and unless it is available. So we need to make sure that India is there, and we adopt. As the sooner we adopt, the sooner we provide. Since you discussed about the evidence, my next question is to Dr. Subodh. So how do you see evidence generation in lung cancer screenings in India, and what can be done?
Well, thank you, Ms. Anushka and IHW for inviting me. As I know, there is no evidence-based guideline currently for lung cancer treatment in India. There's only some consensus guideline which were developed by some experts that what could be the therapy. But recently now ICMR has come up with this, that they are trying to develop a guideline which is evidence-based. That means it is using all the studies which has been published to pool the data and to come up with a new guideline which will be evidence-based, and it will be graded to so that how much confidence is there in the study result. So the India specific guideline are in process, and it is required because here we have different percentage of mutations mutations will be there compared to the probably in US and UK, and also because most of the guidelines which has been developed in West do not take care of the cost effectiveness. So suppose as we know that if there is EGFR mutation in NSCLC, then osimertinib will be the best treatment. But what if patient cannot afford? What should be the next, whether to give gefitinib or erlotinib? So India needs some specific guidelines, and there has been some effort from ICMR now to develop in this sense.
Sure, sir. So what are some of the requirements for the guidelines to be created by ICMR, and what are some of the advanced therapies that are available in India as of now for lung cancer?
I think for advanced therapy, the medical oncologist will tell better, and the requirement which has been proposed by ICMR that they have taken the holistic approach of not only to take care of the effectiveness but also the side effect, and they are not only in the treatment part, they are not coming up with guideline on the treatment part but also on the prevention, screening, diagnosis, management and palliative. For all they have developed some questions, so and it has been distributed to different investigators across the country. I'm the part of investigation team in which we are investigating the TKI, second generation TKI versus first generation TKI and SCLC. So and they have made that it should be grade. It should be the quality of evidence should also be evaluated by grade, and there should also be cost effectiveness part should also be added in that.
Sure, sir. Thank you for your insights, sir.
Just to add to that, he is correct. So the ICM, I'm involved with the development of the ICMR guidelines as well. So they are underway, and it's going to look at all aspects: prevention, diagnosis, treatment, and therapeutics. And as correctly pointed out, there are groups which are working on each aspect of these. They are going to submit their data, what has been generated, and then it's going to get evaluated, and finally we are going to come up with country specific guidelines, most likely by sometime next year.
Thank you, Dr. Navneet, for your insights. Since we've discussed about accessibility and cost effectiveness, my next question is to Mr. Vivek. Sir, in your journey so far, there are several gaps in the lung cancer treatment in India, and the disease is often stigmatized. So how can we overcome this public perception and improve the barriers to make the treatment more accessible?
Okay, so let me share 4 stories quickly. Let's humanize the problem so that we can understand the barriers better. So story 1, and very briefly, a girl 29 years of old, diagnosed with stage 4 lung cancer, never smoker, mother of a 3-year-old son. There was not a single targeted therapy at that time in India for a middle income level person. Okay, this is the case still for the poor people because they can't afford those 3 lakh, 4 lakh per month medicine. So I will connect. So first thing is, it's not about accessibility issue, it is about equity issue. It's not only affordability issue, it is about equity issue. Since I'm seeing this journey 2011 to till now, in last 12-14 years. This family purchased that medicine from US and in India, and they sold all their property. So that's called financial toxicity. That's the unearned barrier, and they were out of money to purchase any medicine, and she was without any medicine for almost 6 months, and again back on chemotherapy without targeted therapy. Luckily, with some program, she found a medicine, targeted therapy with free of cost. Then comes in the kingdom of cancer, stage 4 cancer, the infamous progression. And then they get progression, and the medicine was not available in India. A clinical trial going on in US, Europe, Singapore, Hong Kong, but not in India. So they fight, and oncologist told, go home, take care, nothing can be done. And then they fight with the whole healthcare system, with the work with the government, with the oncologists, but fight and with pharma and work with them, and they bring the trial in India, and she became the first patient from that one. She got saved. Again progression, and this time, and I am bringing the pharma company. Pharma company said that India is not in their picture. They will not bring that medicine to India. And then comes the India media picture. Then that family goes to G News, NDTV, program done. That clips went to that company headquartered in Switzerland. Doctor said nothing can be done, but that medicine comes. This girl become again the first patient. She survived longest of her time. When she was given only 6 months, she survived more than 6 years at her time. That story 1. The clinical trial which got approved because of her and her family, a patient who got enrolled in last September, that patient completed at stage 4 10 years in India. So that's this thing, that's second story. Now, before moving to the third and fourth story, so let me complete that first stories of my and my wife. So that's how we can do. So all this serotonin, melatonin, medicine name was brought to us by us as a patient, and that's the power of patient advocacy. And that's the power not only done by us, we supported by oncologists, medical community. It's a group which needs to be done together. So I disagree with Dr. Bilal who left, and I will definitely convey him message when he said that awareness is a patient advocacy job. No. Why no? Let me give you a third story. Last week, I got a call from a radiologist. Okay, this radiologist is diagnosed with stage 4 lung cancer with EGFR mutation, and he was young, doing great in his career. He was literally crying during the call with me. And he was so happy after talking with me because he was sharing the same thing with a patient of Punjab or Himachal, an uneducated patient, saying that I am not able to access the research, I am not able to access the clinical trial, and what medicine we do have, like osimertinib, I can't afford that. So you don't know, be it other until you are a central government and employee or Ambanis and Adanis, with all due respect to them, who can afford or reimburse, but be you are a policy maker, be you are an oncologist or a doctor or engineer, you don't know when the table will turn, and you can take it in return. You can't afford those 4 lakh medicine, and you will be in the same position crying like that radiologist friend of mine was crying. So it is not only patient advocate's duty, it's all of our duty. And I have put a white ribbon outside at reception. If you getting this message, this white region is with 2 things: lung cancer awareness, and second one is anyone with lungs can get lung cancer. It is not a smoker's disease anymore. So if you go and want to take a picture, post on your social media. I put it there. So that's the third story. And fourth story is, there is a patient in Punjab, house help, okay? And she is needed a targeted therapy, okay? The cost is only 35,000 per month, and that targeted therapy cost. But she's house help, she has 2 kids, she can't afford it because her whole month salary, family income is 10,000. How can she afford? And she's dying. And she's dying, whose mistake it is? Because the policy maker or everyone has the central government CGHS scheme, they can afford. So either you are poor or rich, either you are a smoker or non-smoker, no one deserves to die. Everyone needs the equity. Everyone requires the treatment, and all those barriers which I just mentioned is the thing. And remember, we don't have much time. So let me, before I conclude, let me tell you one more very quick story. So a young girl who is struggling with stage 4 cancer patient was in emergency day before yesterday night. Okay, and after one day, she traveled a long journey just to be part of patient advocacy about lung cancer. I am talking about her. Okay, so that's what more as patient advocate patients we can do. We cannot do alone. We have to come together before this table turns to you or anyone on the call or who are watching this video or going to watch this video. And remember, for us, for you who are struggling with lung cancer, time is more than just a concept. It is the most important thing for us. And I'm sorry, we are very less, so we have to act fast and together.
Can you please give her a mic? Yeah.
People do address lung cancer as a serious, very serious, I would say like an epidemic. So everybody talks of breast cancer, but there's only 1 month dedicated for lung cancer awareness. And who does anything? No one, except for patient advocacy groups like ours. So we had a 30-day program. I did not see any hospital come up with anything. I did not see the government talking about it. I did not see eminent people in our country come up and talk about lung cancer. So till we realize, and like Vivek said, it's not only us. We need not only patients, remember, this is a collective effort. So till the oncologists, till the policymakers, till all of us, you, I, everybody sitting in this room, starts talking more about it, things are not going to change.
Sorry, very important point, because lung cancer doesn't discriminate. Okay, it doesn't discriminate. We discriminate with lung cancer. On October, Charminar was pink. There were some of your hospitals were pink, who are sitting, and I'm telling you, your hospitals were pink. Parliament were pink. Nothing was there for lung cancer. Believe me, lung cancer don't discriminate. Even you are not discriminating, they are not going to discriminate. And that's the stigma. And why it is stigma? It is not that we know that it is coming from the smoking. Stigma is, it is easy just to say that we can't do anything because you are smoking. If you're smoking so bad, ban it. You are not banning it. Everybody is doing smoking and openly, you are not banning it. So it is no one's fault. Remember, it is not going to discriminate. If you want to change it, let's start. If you are oncologist, put the white ribbon. Because I have seen thoracic oncologists doing the advocacy for breast cancer. I'm nothing against breast cancer because stage 4 breast cancer patients are more struggling than lung cancer. My issue is it got glamorized. And the fact, and some of the females are sitting here, by the fact, and my friends from the oncology community can correct me, that more females in India are dying with lung cancer than breast cancer. So just remember that. Thank you.
Thank you so much, Vivek sir, for your stories that you shared with us and the discussion that followed. It has deeply moved us. And we hope through this platform we can take this message forward and create more awareness, specifically for lung cancer, and do some great work in this line.
Sure, one of the panelists said earlier about a 5,000-6,000 rupee, maybe a Jeffertonib being affordable. There are people who don't make that kind of money. So to say that a certain drug is affordable is absolutely wrong. I mean, you go to somebody sitting in West Bengal who can't afford a 50 rupee meal. Where are they going to afford a 5,000-6,000 rupee, drug from? And I've seen people falling at our feet and crying. Do they deserve this? It is available. But what are we doing about it? We're doing nothing. We're doing nothing. And I think even the pharma needs to own up. I mean, I'm sorry to be saying this, but the pharma needs to own up. We need equity in every aspect of lung cancer care.
Definitely, ma'am, we really do. And taking this discussion ahead, my next question is to Dr. Siroj. Sir, since we've heard there's a holistic need and a comprehensive plan for cancer care, lung cancer care, what are your recommendations for India-specific guidelines when it comes to collaborative care models?
Yes, first, lung cancer is multifactorial. All of us has to work together. That is one point. Second, as a clinician, what I feel or seeing cancer, from our side, from India side, we need more research, indigenous research. We have to treat our patient. Research is the strength for West. What they are giving the evidence, we are taking that and treating. Suppose in my clinic, my time is there. I am supposed to use my 30% time patient care, 30% time teaching, 30% research. More than 90% time we give for patient care. Up to suppose 6, 7 o'clock we see the patient. Research I do, like clinical trials I do just for free medicine will come to my patients. I will gain experience in that. That is what, but it's not research. We are producing clerk-like clinicians only. In Western, I have seen they give their life for research only. Here, all of us invest in land, in buildings everywhere. Outside, they put their money for research. One day, so when a medicine is coming up after science, I salute that. Even one day extra life is meaningful, definitely. The question is, it's not our weakness. We have lots of population. In one day we can generate a good evidence also. But that is missing here. So research and innovation is the key. We have to do much more in that. We have to create postdoctorate fellow who are dedicated for research only. Our doctor trained, then they go outside to USA, do research for them. We cannot keep them here. Because I am very happy to see the patient, but I am not tuned for research. I do publication for my promotion only, because I am bound to it. Suppose a funding agent giving money, Then after 1 year they ask for annual report, government also asking annual report, so we have to create that. So it's a pressure. Research is never like that. Any science part. If we are doing that, we will be rich also, our patient will also will be taken care of, best of medicines we can give to them. Genetically we are different, so we have to create that. Consensus is very easy. All the hospitals need to be connected. Now we have many aims also, we can connect each other. So that is, and if you compare the treatment also, it is heterogeneous. One hospital is giving like USA, another one basic. Spirit is not available, you can see that. So at district level you need to have cancer care. I have seen in Western country, they go for training every year. Any physicians, family physicians, they are also sensitized for cancer care and other things. So palliative care is also important. It's very much required. So we are brainy individually, as a group we are nothing. So we have to do that. So it's a holistic approach. But consensus, it's ever evolving. Every day new treatment is coming, every month. So it's a continuous process. A dedicated people should be connected. Cancer grid is there. It should be working more and more. So then only we can tackle this deadly disease. That is my take only.
I mean, I think everybody is working in silos.
Yes.
Everybody is working in silos, and it is only for personal gain. I'm so sorry to be saying.
Yes, yes.
Until we hold hands and until we make a revolution out of it, we are not going to change the scenario. It's only going to get worse. I mean, imagine the air quality. Are we addressing the pollution? We're not even addressing it. When we talk of smoking, there's an evidence which says 1 in 5 women being diagnosed with lung cancer is a non-smoker. What is their fault? And the younger, we have 20-year-olds, we have, women who've not even stepped into their 30s being diagnosed. And the lifespan given to them is, if they don't test positive for a mutation, it is 1 saal. And bas chhod do uske baad. And then nobody talks of, like Sir said and Urvashi said, nobody talks of palliative care. We need advocacy for palliative care also. I mean, and one of the things that we do is, unfortunately, and yes, as we know, stage 4 lung cancer patients at some point there is disease progression. And at that time, they need a lot of support. And we've been successfully able to connect patients living in Bihar and West Bengal to local palliative care centers. They just need a morphine or maybe symptom control. We abandon our dying, which is very, very unfortunate. So a lot of advocacy and work has to go into this field as well.
I'll just make a quick, just reacting to some of the points. So one, I think, as far as the air pollution issue goes, like I said, of course, one, better concrete data evidence being put out by, the medical community as a whole will be powerful, because then it won't just be anecdotal, or it won't just be, okay, this is 1 case or 2 cases. The second is, we have to make people care about it. See, politicians, governments are only going to care if people sitting here care. We have elections coming up in Delhi. Is anybody going to raise this question? I don't think so. And that is the problem, because the only time politicians really care about you, unfortunately, is when they need to seek votes. And so if you don't ask these tough questions at that time, well, they're not going to care. So I think that's where public health, and we just don't have enough public health, professionals in the country at all. I think most people don't even know what is public health. I get asked that all the time, what do you do in public health? So that's exactly what we do. We try to make people realize that just because it's not your problem today, it could be your problem tomorrow. It could be your loved one's problem tomorrow. So you better start caring and questioning, because we are a democracy, right? So we have to question our elected governments on these things. And frankly, the air pollution issue has a very simple solution, and we've discussed it in policy circles ad nauseum. But it's just a lack of political will, or it's just that the state government is a different political party and the center is different, and everybody's fighting with each other. But frankly, the air we're all breathing is really toxic. So I think it's also, in a democracy, it's also about educating people and getting them to use their voice, because each vote matters to the politicians. So that's the only time you can really get their attention, right? So I think that is something we are really missing. And I think the other point is just a quick point on the research, the trials. I really agree with that. We need indigenous research. We cannot keep waiting for patents to expire and 10 years for us to start making biosimilars, and by then we've just lost so many people. And people in the West are on those medicines, and here you are seeing people dying. So literally, is life that cheap for some of us and not for others? So I think that is a big issue, and that can only be addressed if we have more high quality indigenous research. Clinical trials, I've been really pushing for that, because clinical trials, some of the cutting edge ones, don't even come to India. There's one therapy for ALK positive cancer, which is the one I have. And I've been tracing the journey of that particular therapy. It's being developed by a company called Nuvalent. And they started off with the US, they went to Europe, now they've come to Singapore, right there. But they will not come to India, or we really have to kind of go after them and say, please come, please come. So why is that the case? What is the population of Singapore? It's not even one neighborhood of Delhi. And look at India, look at the number of patients we have here, and we are not getting these trials here. So I know that, in the policy space, we had a few instances where there was a lot of unethical practices potentially in trials, and so the trial guidelines were really tightened up. And of course, we have been looking at them, reviewing them also recently, and ICMR and Niti Aayog, various others have been involved. But I think we really need to quicken that up, and we need to discuss with companies, especially the ones doing cutting edge research, and that's often not always big pharma. It might be a smaller biotech firm or a life sciences firm. That what stops you from coming to India? You have the largest patient pool here. Why aren't you coming here? So that is one thing we need to do. And the second is, of course, really put in money into our indigenous research. We fund R&D so poorly, and this is not just on the public sector, it's also on the private sector. If you look at a lot of developed countries, the R&D is mostly funded by the private sector. Here, private sector just doesn't invest enough in R&D. So yes, we want government to step up, obviously, but I think private sector also has an onus, and they too need to step up R&D funding.
I think private sector also needs to step up and start supporting advocacy.
Definitely, ma'am.
Because nothing runs without money. And I just have one more point I just want to ask, I had spoken about, I'd asked a question on how we can ensure that diagnosis is made at the right time, or there's an early diagnosis. I was at another conference, and one of the oncologists said this point, and it stayed with me, that our MBBS doctors are not trained in oncology at all. And that is the reason they miss out on diagnosis. And I wanted Dr. Mohan to make this point, because if you're not trained in oncology, how would you differentiate between a symptom that can be cancer, or they're trained in diagnosing TB? So can something be done about this, sir?
It's a very tough question. Basically, 20 symptoms tuberculosis, 20 symptoms cancer, maybe 18 are overlapping each other. With experience only, we can. There is no substitute. People are bringing artificial intelligence to X-ray reading, and all so many things are there. But suppose cough is there more than 1 month, one should be going to the hospital, do a chest X-ray. Still there is chance of missing it, but we have to health checkup, regular health checkup. I have seen a chartered accountant monthly income 70 lakhs in Bhubaneswar, but only when his friend was going for a PSA for prostate cancer ultrasound, he went with him. After doing ultrasound, a supraclavicular lymph node was there, and he did not see that. And there is a gallbladder cancer with liver metastasis and node here. Educated, all access is there, still they are not there. So India is a complex thing. One formula will never apply. Doctors are trained, individually doctors are very good here with good experience and all. But somebody is practicing, suppose in a rural area, he sees fever and other vaccination, other things, cancer will not come to mind so quickly. So maybe out of 100 patients, we get one cancer patient, like that. So high risk, that is why we are screening high risk patients only, whether they are there. But there are, while going for nowadays, labs are there. Say lady after 40, ultrasound breast is no harm, once in 5 years can be done. Suppose lab result is there, 60 years old male, PSA can be done. These things.
So I'm just going to interject here. Yes. So my only point here is, now when a person from a village walks up to a doctor, they have blind faith on the doctor. So only when a doctor says a certain test needs to be done, they'll get it done. He has no idea about, breast cancer. We still talk of breast self-examination. For lung cancer, he doesn't know. कि भाई 2 महीना हो गया 3 महीना हो गया.
I'd just like to interrupt.
Just 1 more minute. I go to village for awareness regularly, and when I go to my house in village also, many patients they come. But even if mammography is done, BIRATS 2, 3, it's not suspicious. But I never tell she is free from disease. I tell that again after say 2 years you go for ultrasound like that. Cancer is like that. Missing is very easy.
Can I interrupt? So, improving awareness at the first level of healthcare provider, I think the dictum which is that misdiagnosis of tuberculosis, right? So it's very simple. If you have something in which you are able to demonstrate acid-fast bacilli or Mycobacterium tuberculosis in either sputum or any other sample, perhaps even by using the currently available molecular methods like nucleic acid amplification techniques, CB-NAT or gene expert. Yes, accept that is true tuberculosis. If that is not positive, that is not detected, then one should not assume that the constellation of signs, symptoms, and what is seen on radiology is tuberculosis. Agree, tuberculosis is very common. But anything which is not microbiologically or histologically confirmed should have further evaluation. If the healthcare provider in a primary care setting does not have the facilities or the expertise to do that, he or she should refer to a center where that is done. And there, the individual may end up getting confirmed as tuberculosis only, or if it is not tuberculosis, you might end up diagnosing lung cancer at a much earlier stage than waiting for 4 to 6 months of therapy with anti-tubercular drugs, not responding at that time, and then getting it evaluated. So I agree, even at MBBS level, this message should go across that you diagnose tuberculosis, well and good if you have smear AFB positivity or gene expert positivity, but if you don't, do not assume that.
Thank you, Dr. Navneet, for your insights, and Dr. Saroj as well. I think we can conclude this session. We can take a few questions from the audience.
Good evening all, and my respect to each of you, and discussing the importance of lung cancer and the screening and diagnosis. So just, I was really touched with the discussion Vivek sir shared. So I lost my father on lung cancer, so we could not get time. And I just wanted to, just 6 months back. Okay, so yes ma'am. So just wanted to highlight another important aspects. The patients who are suffering, the families are equally suffering, and the mental burden and the challenge they are facing. even the patient is passed away, still the fear of having cancer in other close relatives, that is also very important, and we often miss these issues. And as a discussion pointers, we have discussed a lot on the policies, on the access, on the patient support programs, but we should also emphasize the importance of having counseling for the patients and for the families, those who are suffering and dealing with the patients day in and day out. I would like to bring that to your discussion as well, whether it is relevant or not. So any highlights on this? That absolutely. Absolutely, ma'am. So that is one point I thought to discuss with this panel, which is I thought very relevant. And another point, ma'am, we are also reading so many articles published from different countries, and evidence generation is particularly very important when it comes to Indian scenario. There are lots of challenges in the rural areas. I have discussed with Saroj sir a couple of times that the access to screening programs, and it's not at all properly planned for different states and different, even for the India specific guideline also. So yeah, emphasizing on these points definitely would enlighten us, and thank you for bringing up these questions and discussions to this August forum. Thank you so much.
Thank you. I thought we were going to take recommendations as a conclusion remark, but since we're running short of time, I'll just quickly summarize the session by the very important insights shared by each one of you and the contributions, your contributions in lung cancer treatment. I think we can definitely start with accepting that there's an urgent need of guidelines that are India specific. And India being a diverse country, like Dr. Saroj mentioned, one shoe fits all is not a policy that we can go ahead. We definitely need to train our doctors well and make them prepared for such incidences and make them equipped. We need to support each other, and definitely the kind of work patient advocacy groups are tirelessly doing, we need to support them as citizens first. I hope this stage sets up as a wake-up call for all of us and to all of those hearing us virtually. In a democracy that is by the people, for the people, I think it's time we join hands and create an impact in lung cancer awareness and treatment in India. Thank you.
We would like to thank all our speakers for coming here, and I would request for mementos to be given to our speakers. I request Dr. Sampurna of AstraZeneca to please come up on stage and present our speakers with mementos. A memento for Ms. Vandana Mahajan, Lead Counselor at Lung Connect India. A memento for Mr. Vivek Tomar, the co-founder of Rise to Survive Cancer. A memento for Dr. Urvashi Prasad, former Director, Niti Aayog. A memento for Dr. Saroj Kumar Das Majumdar. And a memento for Dr. Subodh Kumar, Professor AIMS Deoghar. I request Dr. Nusha to come up on stage. We have a memento for her for steering this discussion. I wish request all of you to gather for a group photograph. Thank you to our speakers who joined us virtually as well, and thank you to the speakers for taking the time to come here. I hope it has been a very informative and educative experience attending the Lung Health and Oncology National Conference 2024. It was, an eye-opener for me to know that more women die of lung cancer than breast cancer in our countries. Of course, it is important to detect the disease early and have targeted treatments for effective treatment, but we also have to have greater awareness and equity when it comes to using the new treatment modalities that are very effective. Thank you all for your presence here, and we'll see you soon.